All right. Excuse me. We'll go ahead and get started. Uh, Hopefully everybody can hear me. Thank you very much for attending the fishing trip. My name is Tamara McMahon. I am the Director of Engineering for the Medical Informatics Department. And Dr. Russ Waitman will be joining us in about half an hour to discuss HERON as well. So it looks like from the enrollment, it looks like we've got a variety of interests, which is good. That's always good to have variety in these workshops. A different variety of backgrounds and a variety of research interests. I would ask everybody to go around and introduce yourself. Please tell me your name, what you are, what your department you're in, and your area of research, what you're interested in, how you've been using HERON. We do have people joining us remotely, so I will be trying to repeat questions as you have them throughout the workshop for remote users. But this is going to be kind of an interactive workshop where interrupt us. It's not going to be a big teaching session. We're going to be talking about functionality, and we welcome a lot of questions as we go. Looks like most people that have signed up are either beginner or never used. We've got a couple advanced. But it looks like the majority are beginners, so which means you've probably been in HERON and used it before. So I'll try to focus this on not the very, very basics of, how do you drag and drop to do a search. You'll be able to, for the beginners, you'll be able to pick up on that pretty quickly, but I'll try to go more towards people that have used HERON. So once again, my name is Tamara, and welcome. And Maren?
I'm Maren, and I'm Tammy Joy Cabot. I'm a health economist in the Department of Health Policy and Management, and specifically the so we're hoping to look at comparing some early maternal child health.
I'm John Hamilton. I'm a PhD student in health policy management, and we're here to look at two things. First is people with low-risk prostate cancer with the rest of treatment options, and second is more of a nutrition opioid use disorder and treatment.
I'm Matthew Taylor. I'm in our dietetics and nutrition department, PhD candidate. I also work over at the Alzheimer's Disease Center. I do research looking at brain metabolism, and so I primarily look at Alzheimer's right now. So I've got some burning questions looking at some nutrition-based profiles and potential Alzheimer's outcomes. So.
Hi, I'm not a student, so just started the semester. I'm interested in childhood obesity. I want to find something interested in the database.
Are you working with any professor in particular? You said are you collaborating with any faculty members?
I'm working with Dr. Sullivan from Nutrition and Dietetics.
Sullivan.
I'm Alexandra. I am a research assistant over in the neurology department and doing research on Parkinson's disease.
I'm Drew Fox. I'm at Posen Brain Imaging Center. I work with Dr. Laura Martin. I'm a postdoc. We study neurobiology of addiction, and we're hoping to use frontiers to find smokers, more or less.
My name is Maria. I'm relatively new to the Kansas City area and the anesthesiology department here. I have experience in musculoskeletal research, clinical research, qualitative methods, and would like to get a handle on a retrospective cohort of patients seen at the Spine Center, the Asher Spine Center, by interventional pain anesthesiologists, and see where we can go forward for perhaps developing a prospective cohort in 2017.
My name is Marie Pavlovic. I'm an infectious disease fellow here. I'm interested in duration of exposure to some antiretroviral drugs in development.
Sarah, I work in conception with the number of insurance, trying to get information. senior leadership as being the part of that business. And we'll be on the mass for the 8-10%.
I'm Nathan Graham. I work in bioinformatics with HERON. Side of things, so concerning the breaks.
I'm Denise Maple. I'm actually a nutrition for the area too. My background is I have a PhD in epidemiology, but I come from radiation oncology. So my goal is to help our faculty go in and do some retrospective research, get some databases.
Hi, I'm Denise Martin. I'm the research coordinator and analyst with also this research on Dr. Chad. He's been studies, also interested in random purposes.
My name is Mark Ricard. I'm a PhD student in the T department, and I'm interested in just identifying cohorts through
Hi, I'm Margo Badigoda, and I work with Medicine too. I think management and so
Hi, I'm Shopee. I work with Canada. The department, and I'm just going to go into my analysis.
My name is Vivek Mehta. I'm a second year medical student, and I'm doing research with transcatheter aortic valve replacement with Dr. Sauer.
Right, thank you. Did we get everyone? I think so. Okay, so there are quite a few different interesting areas of research. The good thing is we've got data about all of this stuff in HERON. Let me go through a little bit about what we're going to discuss today, the agenda. So for the first hour and a half, or first 2 hours actually, we're going to just talk about what type of data is available in HERON, how to search it, some advanced features as far as limiting your set to a same financial encounter. We're going to talk about modifiers and some of the analysis tools. We'll take a short break, and then we'll come back and talk about some temporal queries. If you're interested in finding out, patients that had a certain event happen before another, you can do that in HERON as well. We'll also talk about bringing in a REDCap project into HERON. If you've already got a patient set that you've identified, and you just want to collect some additional data on them, it's sometimes easier to bring a REDCap project in. We'll discuss data fulfillment. And so once you search HERON, you get these numbers. Great. What if you want data on them? We'll discuss the process to get that data and what that data will look like. Because it's very raw data, so I want to introduce you to what you'll have to do with that data once you get it. And then we'll touch on something called FABLE, which is part of the Greater Plains Collaborative. It's like an I2B2 for the Greater Plains Collaborative, which is a CDRN that our department here works on. And I'll discuss that more in detail later in this morning. And then we'll break for lunch, and we'll come back, and we'll pretty much have a hands-on. That'll be a time when you guys will be doing your searches, and we'll have people here that can walk around and help answer questions. Because really the best way to learn this tool is to get in and use it. I can talk all day long, but until you actually get in there and start searching, that's when you really start learning this tool. And then we'll have a brief wrap-up at the end with closing thoughts. First up, I wanted to mention we do this day-long workshop once a year. We also have clinics that we do twice a month. And it's the first and third Tuesdays. It's over lunch hour from 12 to 1:30. And you're welcome to stop by with any questions you have about the system. We discuss both REDCap and HERON systems. So that's another great way to get additional information. This is the HERON website. And most of you have been here before, so you all have logged into HERON before. I wanted to show you some tools here that might be of use. There are help pages specific to HERON. There's training videos you can always watch about some of the functionality. We've got some frequently asked questions. This Lunch and Learn, that's what I was just discussing. You're welcome to drop in. If you want pizza, we offer pizza. We just ask that you register in advance so we know that you'll be there. You know how much pizza to get. You can also request a consultation. if you are having, if you want us to do the work with your team on this, we can. If you want additional information, you're having a hard time searching here, and you want maybe a 1 hour training, go ahead and fill out this request a consultation list or survey, and we'll be happy to meet with you. We've got what's required to log into HERON, and then here this talks a little bit about some of the data repositories that are within HERON. So let's go ahead and start. Within the training, so here's a brief example of some HERON training materials. How you access it, what is available within HERON. One item of interest that it sometimes gets people, you can only access HERON from a secure network. If you are off-site, you need a VPN. If you are a student and you have VPN access, you still may not be able to access it. You have to have permission into a special group. So if you're trying to access HERON remotely, try to VPN into the system. There is a link to the HERON blog. And this has up-to-date information on the types of data that are within HERON. Real quickly, we had a few people that joined us. I wanted to introduce them as well. Li Wang, she's a clinical informatics coordinator. She, as well as Marin, answer a lot of questions about HERON. So if you have any questions, you'll more likely be talking to them. If you request any data, they'll be the ones that are pulling the data for you. And Russ Waitman just joined us. Russ, you're welcome to sit up here too.
Oh, no.
Doctor, you want to introduce yourself?
I'm Alan Hughes, nephrology.
So, let me get here. So this is an example from 2015. This is a little out of date, but it will give you an idea of what types of data are within HERON. We've got information from our O2 system, from our cancer registry. The reason I bring this up, this is kind of an important page. Anytime you log into HERON and you have a new release, there'll be something that pops up that you'll need to acknowledge. And it's kind of frustrating because you're like, oh, I just want to search, let me just acknowledge this. But this pops up because it shows you what date ranges of information we have, as well as if there's any new functionality. So if we bring in a new data source, it'll be highlighted. If there's any type of new search capabilities, it'll be highlighted as well. So this is important because you'll notice alerts that goes back to 2007, but the cancer cases go back to the 1950s. You've got some demographic data going back to 2000. So you got some microbiology stuff to 2003. There's a variety of date ranges, but the majority of it is from when our EMR O2 went live in November of 2007. So if you're doing a search for cancer and you just look up, see how many in the tumor history, okay, how many people have lung cancer? And you could get this great number, but then you want to start doing this searching with a medication, that's going to immediately limit your search results to 2007 on, because we only have medication information from 2007 on. So it's really good to know the dates of the data that you're looking at. All right, so we are going to go ahead and launch HERON. And this is the main page. We've also got, you can see in here, there's HERON help. That goes to the link that I showed you previously. There's also I2B2 help. This is standard. This HERON is built on the I2B2 tool. And this is out-of-the-box standard I2B2 help. So this is great if you're wondering, okay, how do I just do a search? And we'll teach you to drag and drop. Or what does it mean to treat all groups independently? That information will be in that I2B2 help. This is where you've got your terms that you're going to search on. This is where you've got, you'll see a shared folder and your own folder. This is where you can share searches with your coworkers. I see everybody's folders, but you would only see them I'm sorry, I see everybody's folders, but you only see your folder in the share folder. And down here you will have your previous queries, and you can pull queries up into a query tool, and you can reuse your queries, rerun them, see if numbers have changed over time, or build upon those queries as well.
And anybody in the shared folder can create a subfolder. So if Marin's doing something really exciting around social status, she could create Marin's social status folder and then share that with everyone else.
You can see within our shared folder, we have quite a few folders within. So it's great for collaborating with your colleagues if you're building upon searches together. So we'll go ahead and do a sample search. Does anybody have, I figured this we would kind of build upon queries that people are interested in doing. But there is really across the board as far as what researchers' interests there are. Does anybody have a topic they'd like me to start with?
I can give you an example. Sure. I mean, so for instance, we want to know how many people were identified, how many people between, say, 18 and 55 went to the hospital and identified as smokers, and if they smoked like enough cigarettes per day to qualify for a study, for instance.
Okay, so I will start with the age. You said 18 through 55. That's going to be, age is going to be within demographics. And I'll pull over just the groups. We're looking for anyone that's 18 to 34, 35 to 44, or 45 to 54. You said through 55, so we'll pull over that 1 year 55 as well. So you can see you can pull over at the folder level or at the leaf level within.
And one kind of small comment, you would be looking to recruit 18 to 55-year-olds, their age right now. There's another place in the system where if you were doing a pediatric study and you said, I want to look at the 1 to 2-year-olds when they were 1 to 2 in the clinic or in the hospital, but I am now looking at them later. There's also a concept called age at visit that lets you say, I want to know how old they were at a particular visit. So you have both options. Right? Okay. But we'll start with the most common, which is you want to know how old they are right now.
Yes, and here under visit details is that age at visit. Okay. So currently they're 18 to 55 and smoker. So let's look at the smoker information. We have a folder in here called history, and within it we've got a social history, which includes tobacco usage. So within tobacco usage, we've got smokeless and smoking tobacco. So you're interested in smoking.
Yep.
So you can get as specific as you like or as broad as you'd like. So you can see I can pull over this smoking tobacco use folder into a group, but this will include quite a few unknowns if they ever smoked or never assessed or never smoked.
Right. And then there's also a packs per day. So there's a couple different parameters in the EMR of how you assign smoking. Mm-hmm.
So there's, at the higher level, there's also a never, not asked, packs per day, a smoking quit day, years of tobacco usage you can search on, and then there's also a yes for tobacco usage in general. So I'm going to go over, and I'll pull over the yes. And how you were interested in packs per day, correct? Or,
yes.
And is there a specific amount of packs per day that you're interested in?
So I don't know how granular it is, but usually we are trying to recruit people who smoke at least 10 cigarettes a day, which is a half a pack. So usually we're going for half a pack a day or higher.
I wonder if we'd have that in there.
Yeah.
That's a good question.
Well, we can look at the data. So typically you'll see 0. I think if you look at the number of facts, there's a lot of facts. So one comment I just make here, what's nice about what we do at HERON is we show you how many people, you don't have to even search. Every fact we show you tells you here's how many people have had that fact and how many times it's been observed. So you'll see on a lot of these, the yes flag, for whatever reason, they've only attributed that in some workflow to 100,000 people. But the packs per day question has been attributed to over 500,000 people. Many of those, it's going to say 0. So if you want people with more than half a pack, I think it's going to be numeric, and we'll use fractions. So you can probably drag in the packs per day, and maybe just use that right now for the only criteria and get rid of group 2.
Okay.
just to make it simple.
Shall I
And
use?
set the value to be, what do you think, greater than or equal to 0.5 maybe?
Yes.
Does that have a pattern roughly?
Yep. That's what I would do.
Yep. And then she can delete group 2, and that's going to let you know the number of people of the age range with that PACS criteria. Now, the other component you said you wanted to know is, when you said the hospital, do you mean hospital or clinic, or do you want to know they actually came in for an inpatient stay? Or
You know what, actually, that doesn't matter.
Okay. So there's your
Yeah.
total.
Yeah.
And to just verify it, if she changes the PACS per day to greater than 2, it should go down. So, and we're going fast here because she's
Yeah.
right-clicking with her mouse, and you can follow along. Try to follow along if you can, and just get used to using the tool.
So what I did is I right-clicked on it, and there's an option to set value. And so I went in and changed the value, and that dropped quite a bit.
Mm-hmm. And it shows you visually in the tool. It says, okay, now I've set it to greater than 2 PACS per day.
So, just to be clear, what exactly does that number mean? That 34%?
It's the number of unique patients that meet that criteria.
Okay.
So it's one patient. Patient is counted one time, so it's unique patients that are either within the 18 to 55 year range who have recorded smoking of more than 2 packs per day.
And this dates back to 2007?
Correct.
Okay. Why don't you change it back to 0.05 and then show them the timeline? The only other comment I'd make about this is what you're seeing is this means at some point in their electronic medical record they've had greater than 2.
Yeah.
So it could be that they had smoked 2 packs a day at one time, but then later they quit.
Okay.
So you can actually do work where you could build off of this and add in the third group and say, well, how many of those people who smoke more than 2 packs a day have also been reported as never smoking? And then there's advanced functionality where you could see that this event happened before that event, but we don't want to steal the thunder.
Yes, I get. I mean, I would definitely want to exclude people who had been reported like recently as having quit. Like those aren't people we're particularly interested in.
Mm-hmm.
So yeah, that's cool.
So like if she hovers on this timeline, I don't know if you saw how she kicked off the timeline. When she hovers, it'll say that person's a 1 pack a day smoker. That person is a 0.5 pack a day smoker. So this timeline tool, when you run your query, it will let you make a timeline. Sometimes it takes it a little bit of time because it's so much data, but it's very useful for you to check your data. So in your example, if you said, I don't want to include anybody who has also had it in their record that they quit smoking, do you want to show them how to do that, Cameron?
Yeah, I was just saying, you might need to move up closer to the microphone.
Okay, sorry about
So
that.
you can even. And what was it that you wanted me to show?
Well, he was saying he wanted to exclude people who have also said they quit.
Okay. All right, so let me find quit in here.
And actually, I don't know if we want to go here, but it would be even more useful if they quit within the last year. That would be even more useful.
And you want to exclude people who quit in the last year.
Yeah. Because a lot of people, again, like they will say they quit, but that will be 3 years ago, and they will start it again, for instance.
Okay, so I pulled the quit over here,
Yep.
and I changed it to exclude. And I'm going to change the dates in here to within the past year. So I will go back. So one thing about HERON data is it's de-identified, so you're not seeing the real dates. Everything's date shifted up to a year in the past. So I will go back to, let's see, it's December. So if I try to do a year, I usually go back a year and a half due to the date shifting. So I'll do July 1st, 2015 to present. And we are going to see what that number looks like. We're going to get this time right. That's how we can.
You want to cancel?
So see this little check mark here? That's how I got the timeline before. I'm going to go ahead and run it.
So what was our number before? We were in like the 49,000 range. So this should be a lower number because it's excluding people who've recently said they quit.
And you said you were interested in recruiting, is
Yeah.
that correct? And I don't know if you've heard about the Frontiers Participant Registry.
Yeah.
So you can also limit your query to Frontiers registry patients. Let me see here. I'm going to go ahead and add a new group. And let me pull the Frontiers over.
At no cost at all, you get an extra group.
So for those of you that don't know, the Frontiers Registry is a registry of people who have agreed to be contacted in the event that they meet certain criteria for a study. So this brings it down, you've got 2,558 people that you are be able to contact that meet your range.
So those would be people, you could kind of go through this Frontiers program and contact them directly. Now, if you knew that Dr. Yu was really excited about smoking cessation and nephrology, you could also browse the clinical services down at the bottom. And you could say, well, I have a relationship with certain clinics that are fully on board with my study. And you could do work to use the various ways we categorize clinical services. And you could say, I want to also recruit, with my colleagues in an internal medicine division. And you could drag that in and say, I know that they're really on board with my study, so I may want to, in addition to the Frontier Registry, I'm working with my nephrology colleagues to recruit. And like you saw on your exclusion criteria of quit smoking, you could look at things like how many people have gone to nephrology recently, so you get a feel for how many are current, potentially more active patients. Whereas this data, because the billing information goes back so far to 2000, you may see a lot of people, but they may not be current patients. But you picked up some more people. So that kind of shows you, depending upon what you're trying to study, you maybe have a situation where the volunteer registry is a good basis, but then in other cases, you can evaluate clinical services that might be your partners in research or your own division to understand how to recruit.
That's a quick
So
question.
then those, I'm sorry.
Go ahead.
So then those people would be flagged as, need consent over and above the 2,900 we had on the last query?
What typically happens is that what's interesting about the Frontiers Registry is we got an agreement with the clinic practice group to create a program that when people check in at the clinic, they can say, I'm willing to be contacted just in general about research.
Right.
So that's why that pool of about 45,000 people are kind of an asset that if I was a physical therapist who's a researcher and don't have a clinical relationship, it gives me a subpopulation that I can go through the CTSA program to recruit. You're still going to have an IRB, still going to have to consent them. But in general, if you want to contact a patient, you need to go through their provider to contact them. So I'm just pointing out, we have a lot of great clinical colleagues. This helps you kind of understand if you were looking for a clinical service to develop a partnership with, you can kind of evaluate these different services and see, well, which ones see most of the patients I'm interested in. Does that make sense?
Kind of. I'm just wondering of those extra, I don't remember exactly, 300 or 400 patients you pulled in with this query, what if some or all of them said, do not contact me about research, and you're wanting to contact people, get this bucket of people to contact?
I think most of them just have probably not ever been asked the question.
Okay.
So we don't have, for the most part, an explicit flag in the workflow that says, I'm not interested in research. It's more of the registry's a volunteer thing. So there are going to be many people who come through the health system that don't even think about the question, where that piece of paper isn't in the workflow. So normally what would happen is, the clinicians in their practice group would always be thinking about, potentially, this patient is eligible for a trial, but HERON can help you know, well, actually, if I'm doing nephrology, a kidney-focused trial, and I'm working with Dr. Yu, this helps me know how many people can I work with his division to recruit. But you have to be in partnership with them, and we want to do some more refinement, like how many recently came in the last year, so you can kind of get a feel for what's the volume of patients that you might potentially accrue. So we're doing a study called Adaptable, which is an aspirin trial that's a pragmatic trial through PCORI of low dose versus high dose aspirin. And in general, we're going to now approach some of these registry patients But the first pass was Dr. Kamal Gupta in Mid-American Cardiology is our local lead for this national trial. So he worked with MAC, the clinic group, to say, okay, here are the number of MAC patients eligible for the trial. Now let's send them email letters to see if they're interested in the trial. If he then wanted to work with Amy Ladner in internal medicine, he would contact general internal medicine, contact the various divisions and say, now can we approach your patients? But it's always done in partnership with the clinical. In the case of the Frontiers Registry, what you wind up doing is you can move forward with your recruitment, but you also, out of courtesy, will generate letters that go to the clinicians in those practice groups. So is that helpful at all? Kind of showing in one case it's critical to have the clinical partnership first, whereas in the registry you can begin to approach them, but out of courtesy and acknowledgement, you'll notify them via letter as well.
And people can opt out of that Frontiers registry. There is the ability to opt out, and then they are removed from Frontiers bucket.
Can I ask a quick question about something you showed there? What's the difference between clinical service and clinical service department?
Very good question. So what we have here is, and we probably need to do a little bit better job of organizing this, some of the data we have is based upon the IDX billing system. So these ones here, and we probably ought to label them better, the outpatient visits folder, all of these are kind of for the clinics that use the UKP billing system. This is showing what their clinical departments are. These inpatient visits are coming out of Epic, out of some of the departmental categories in Epic. Now, the clinical service departments are a newer categorization we found out of Epic, right, Tamara? So that's why. So what happened historically is originally the hospital turned on Epic in November of 2007, but none of the clinics, except for I think part of the cancer center and the JDOC clinics or Jayhawk clinics, were actually using Epic. And then it's piloting in November. A pilot started in 2010 to start piloting Epic in the clinics, and then it kind of rolled out 10, 11, 12, and then I think some stragglers came on later. So when you're trying to find out like how many people visited nephrology or visited dermatology, you will only have very recent data out of some of these visit informations coming from Epic, whereas here, this is going to give you that data back to the year 2000 of how many people have had bills from UKP.
So clinical services should be more comprehensive, or there's some overlap?
There's going to be overlap. Yeah, so you could do that, for example, we could see, and then when they rotate through the inpatient visit locations, we will see things like, did they go, and the challenge here is there's a lot of complexity in terms of Epic of the different ways it tags a visit. So these are some ways in Epic where you're seeing tagging that this set of patients goes through the cancer center bone marrow transplant location a lot. These service departments are going to be similar but slightly different hierarchies for visits within the hospital, within, in this case, inpatient hospital locations. So, here you're seeing another categorization in Epic. We probably haven't done as good a job as we should to fully reconcile the differences. And you can kind of get a feel, too, for the amount of data being shown. This new outpatient visit folder has a fair amount of workflow. So I guess if we looked at nephrology, let's see if it's in here. This is one workflow showing that people are traveling and coming into 2 nephrology locations in the outpatient workflow. This down here was showing from the billing system that has been used for a long time by the nephrology division. Here are a much larger number of patients back to the year 2000 who've had bills created for them. And then you would see also on the inpatient visits data could be in here as well if a patient. So here we don't have any status that nephrology was the clinical department they were located in. That may not be a location they could be assigned to.
So I think we'll start looking, I kind of went right into searching. I want to take a step back and talk about the different types of data within HERON, because there really is a lot of data. I'll go through the folders and some commonly used items. So at the very top, you've got alerts, and this is, you'll notice the word draft after it. It's something we've brought in, and we're looking for feedback on it. You'll see that in a couple different places, because what happens is we'll get asked to bring in data, we'll bring in data, but until somebody really, really uses it and engages with us, we don't know if it's organized exactly the way that's most beneficial. So in here you'll find best practice advisories, you'll find you know, all sorts of alerts, drug interactions.
And so I'll just comment, open that back up again. So this is an interest of mine, and Mei Lu, who's faculty with us, has done some research on this data, which is, this is data about the EMR utility. So what we have in here that's interesting to us is if someone is being put on, say, 2 nephrotoxic drugs that interact, is that alert firing, and what are people doing in response to that alert? So we went ahead and harvested all that data. We have other data from nursing about when they give a barcode medadmin, when they're giving the med, you know, does the nurse get an alert that the dose is incorrect or too high? So if there are people doing research in nursing practice or interested in adverse events, that could be very useful. Also, we've harvested what are kind of locally built best practice alerts out of Epic by the hospital team. So there may be some things in here that if you're working closely with the hospital and you're interested in, you know, like here's one where they've got some alert bugging doctors about co-signing their orders, you know, and you want to know, well, how effective is that alert really? You've got data in here where you can kind of see how many times, you know, that it appears the alert is firing, and then what are people doing in response to the alert? Are they canceling that in the workflow? Are they overriding the alert and so forth? So I know, for example, there's a lot of interest in sepsis, and we've got some sepsis alerts that have been built in the workflow of the hospital, and you can kind of see when those are firing.
So just a question, since those alerts are customized during implementation, do you get the value that it's set at, or just whether or not it's ordered? So like maybe co-signing an order, so co-signing completing a chart, maybe after 24 hours in some places, or maybe after 18 hours or 12 hours. Do you get that value as well as whether they canceled it or actually performed it?
All we're getting in here is what did it fire.
Okay.
We don't know from this data what was the logic used to fire the alert.
That's supposed to be good.
Yeah. But I would assume if you're really interested, you need to go work with people who built the alert and say, hey, you know, but it does provide you a pretty quick way just to see, well, if I've got an issue with getting sepsis patients managed properly, how often is the alert doing anything? You know, is it an effective alert or not? Could potentially help you there.
We've got allergies. This is where you get your drug interactions. You've got, again, this one's in draft. One thing I did gloss over also is you'll notice the 2 numbers here. After each of these folders, you've got a number with the patients, a number with facts. This is the number of unique patients that have been attributed, and this is the number of observations for those patients. So if you're doing a search and there's no number attached to it, don't search on it, because that means there's no patients attached to it. And sometimes you will come across some concepts that don't have any patients. You know, they're standard out of the box EMR concepts that haven't been built.
And when you open these folders up, we apologize a little bit. They don't fit in a terminology like you'll see the meds. They're kind of alphabetically organized. But it does create a way for you to look for allergies, you know, by name. The other, you want to show them the find button? That's another one. So, you know, you could browse those trees like we've been browsing now, but you could also click that find tab and then choose search by name. So then you could look in the allergies. And is there an allergy someone wants to look for? A drug or anything? Peanut? Okay.
Let's see if there's anything in peanut. Here we go. And from here, you can pull this into your search to limit.
And this is an important thing she's got here is what's a very nice tool in HERON is when you're in these views where you can search by the name or by the code, when you mouse over and you hold your mouse over the term, it's going to show you the path of the concept, which is very important because sometimes you may be looking for something like one particular drug, and you want to note where the path is because you may want to go back to the hierarchy and find neighboring terms that could also be relevant to your search. Does that make sense? So if you were looking at ACE inhibitors as a drug you're interested in, you may be really smart and you remember 5 of them, but oh, by the way, there's a couple more esoteric ones you forgot about. And so using both the text search and then going back and look at the tree, they're complementary tools that can help you find your cohort. And so you can see, like she showed, sometimes it's been expressed as a drug ingredient, and it's been described both in terms of the oil versus the flavor versus the peanut itself.
You can search by term, limit it to a specific folder, or you can search by code. If you know, for example, the ICD-9 or ICD-10 or CPT code. It's the quickest way to find that code in the system.
To be honest, does anybody not know what an ICD-9, 10, or CPT are? Everybody knows them? Don't know? Okay. So when you look at how concepts are organized medically, there's a thing called ICD, International Classification of Disease. So when physicians assign diagnoses, there's different ways to organize them. And for a long time in the United States, when the bills went out, when you got paid, you had to code them to this standard called ICD version 9. And then a couple years back, the country transitioned to a new terminology called ICD-10. Now, when the physician is in the EMR, they use a terminology internal that they buy from a company called IMO that lets them choose more physician-friendly concepts that then can roll up to either 9 or 10. And so it can get a little intricate, but you have options in here to look for the 9s or the 10 codes, depending on what you want to look for. And you may find, because we've gone through this transition over the last couple of years, if you're looking at a large respective cohort, you may need to look at both the 9 and the 10 term. And one other comment I'll just make is, what you may find when you're in here searching by names at times, you may get very frustrated because sometimes you'll search for something and it will be all over the place. It will be a term that's used a bunch. So if you ever search this and you say in any category, you're searching across millions of concepts. So the system can be a little sluggish. And even when you restrict it to some folders, you could find that there's a whole bunch of acetaminophen. So one thing to keep in mind is this little checkbox of show options. It normally only searches for up to 200 terms, but if you are searching for some things that you know there's going to be a lot of those terms, you may want to bump it up a bit so that you don't get frustrated by the system. So if you typed in acetaminophen, what you'd see is if I didn't do that, E, just E, you'd probably see, well, it didn't type it in right. It's going to search a while because it's trying to find all these concepts. And your question?
I was just, one of the topics right now that being discussed at the state level is non-medical exemptions for immunizations. If you were searching an immunization status, it would be better to look at the allergies, looking at like allergic to eggs or other things that may be within the vaccinations, or is there a different process that you could search on who's been exempted from getting their immunization vaccine? Because there's both a religious exemption as well as a clinical exemption. Right now, it's legal in the state. And I didn't know. I assume that being a patient chart would be somewhere, unless it's a note or progress note or something that maybe you're not finding. Just something to think about. We don't need to discuss it right now.
Oh no, that's a good one. So I would say, one, you could see. I'll tell you, there is a specific immunization record in Epic that has some structured data, and we have never bothered harvesting because no one's ever really said, I really, really want to do immunization research. So one thing might be, you're out of luck. We don't have good data about it. The place you might see it could be under the medications for the delivery of the immunization, as well as potentially under the procedure order section. There may be a part where they're assigning an immunization status. So that would be another place where you might do some searching in both the medications for the immunization as well as for the orders. Right now, I would say. But if that's an area that's of big interest, follow up with us.
just the legislation right now being brought to the legislation that's being proposed to include personal exemptions this year. What we've done.
So after allergens, we've got cancer cases, and you'll see there are two folders that are called cancer cases. One is abridged. They have the same number of patients. This is the more commonly searched. It's a subset of that other cancer folder. The cancer, this is the tumor registry data that goes back to the 1950s. So as you can imagine, standards have changed a lot over the years. So this is the more commonly used standards. It's got the high terms about your site summary, what type of cancer it is, date of diagnoses, the items that people search on more frequently when dealing with the tumor registry.
So when we loaded the original full registry, it's a lot of stuff, and it's still the whole folder is there. But when we talked to John Kegley, who works with Susan Lai in the registry, these, for more recent cases, are probably the ways you want to approach looking at stage and grade. Now, if you want to get really deep into, well, tell me what was the standard used back in a certain time period, you get the idea. There's all these much more different ways cancer can be staged and graded. So that's kind of where we have the whole library available to you, but we've also kind of created an abridged copy. And that's another important thing to note about HERON. We can basically create these folders that point to the same underlying fact. So essentially, if you were to look at the site SEER summary data out of here for the main categorization of the breast cancer, I think unless something's broken, this number of breast cases, that fact that they were coded as breast according to SEER criteria, cross my fingers, should be exactly the same here. Okay, so it's just showing you that it's kind of like we got two Chinese menus that point to the same thing in your refrigerator. But that's what's going on with these ontology folders, is we can kind of organize facts, and you can sometimes, in some cases, you'll only have one folder that has the fact in one spot, but in a couple of cases, like ICD-9 versus ICD-10, we may be pointing you to the same underlying concept. And that's also definitely the case for flow sheet data.
Question?
Yes.
Has all of HERON data been updated to ICD-10? Which one did you pick? ICD-9 facts or ICD-10, or is it both overlapping?
That's a great question. Go ahead and pull up in the folder. So I'll maybe go to the board and go drill down and show like an ICD. Go down at one of the trees and show the DXID.
All right.
So this is a really great question, and it's probably as good a time as any to bring it up. What's happening in the clinical setting here is with diagnosis codes. HERON has a diagnosis code. Now let's see the fact. Someone reported a diagnosis. And that, for our data, could come from a couple different places. I'll show you a couple. One could be, like I described, many of the clinics use a billing system called GE, General Electric, IDX. So it could be coming in from the IDX billing system. It could also be coming in from Epic, the electronic Epic/O2, our EMR. Now, some of the data, when it's recorded in a billing system, they just want to get paid. And so the concept that's recorded by the billing people is going to be an explicit ICD-9 code like 331.0. And that may have been recorded back in the day when they were billing with ICD-9. So what you'll see is some of the concepts that were billing derived will have been coded in 9. And that is never going to exist in ICD-10 because we're not going to pervert the data. You know, we could potentially figure out crossmaps for you, but you can come and consult with us if you do that. There's also, once they made the transition, they may now be using ICD-10. And I can't remember off the top of my head what 331 is But you'll notice the ICD-10 often start with things like G. So the ICD-10 codes start with an alphanumeric and then have a string of numbers. Sometimes they're a one-to-one match. You'll see some places where the folders kind of, this one matches up very closely with that one. Now what's interesting in EPIC and EMR, the fundamental concept that is being chosen by the clinician, and I believe also to a certain degree by billing data, is they use an internal code called a DXID. And it can be very specific. It can be more specific, or in other cases, more general than the ICD-9 or 10 code. So you'll see here, that's a diagnosis code B20 or HIV. And then here, underneath it, there's a lot of different ways that they're choosing to record HIV status. So notice there's one where they're saying this specific subgroup has acquired immunosyndrome AIDS, where their CD4 count was less than 200. Very specific, more specific. So what happens in that setting is we have maps that basically let us say when this DXID is chosen, let's say some number, that really doesn't make any sense to anybody outside of KU and the EMR here, we know how to map it up to ICD-9 or ICD-10. So what you'll see in our system is you will notice at the highest levels, we have certain places where the same concept is visible under either tree. But we have other concepts where when billers build it and all they told us was the 9 or the 10 code, then it's only going to be in the 9 or the 10 folder. Does that make sense at all? And you could play around with this and kind of see how many more you pick up if you look at ICD-10 versus ICD-9. And so for some things, if you're looking mainly at maybe very specific clinical terms, it's going to be the same number no matter which tree folder you use. In other cases, you may want to broadly look at the population to include as many of the codes as you need. The other concept we could introduce here at this point in the conversation is modifiers. Sure. So you'll notice something we showed you briefly when we were looking at the alerts, where we showed underneath the alert concept, it had a folder with that little blue star, and you could see, well, which ones were overridden or canceled. Here, what we're able to show you in the diagnosis tree is we can tell you who set the diagnosis. Because that's sometimes for people who love thinking about codifying data, they get really excited. They say, I don't trust the billers. Those guys overcode everything. That's not truth. And they say, I want to look at what the doctor said. And then the other people say, boy, those orthopedic surgeons, they never document anything on the problem list. I can't trust them at all. Let me look at what the coders said. So you got that flexibility here where you can look to see for these categories how many of those records have been set by either group. So if you wanted to say, I specifically want to know how many codes for HIV have been coded in the clinic billing system, IDX, I can find out there's the number where the coders coded it using that ICD-10 term. If I said I want to also look where the hospital did it, I can OR them to these together. In the context of IDX and UHC, there's a concept of a principal problem. So if you said, I really want to know that was the principal reason for the visit, I've got a flag that I can use there to say that the principal problem was this, and I can union them together. I can say who had the principal diagnosis, and I know it happened in the clinic billing system at the same visit. We can talk about why we do that later. Does this give you a feel? So it's kind of like we're bringing all this data together. It's powerful. Sometimes it may be like, oh my goodness, I got too many controls. But you may want to, if you were really, really suspicious and you said, well, I want better confidence that they both were billed for it as well as the clinician recorded it somewhere in the EMR. Or maybe I want to know it's really on specifically on the problem list. So this might be a case where you really want to know where it's being actively worked as a problem by the clinician, as opposed to it was denoted as a comorbidity during an encounter. Question in the back?
So just to clarify, So there isn't necessarily something similar to like a concept roll-up for like a condition like heart failure. There are hundreds of ICD-9 and 10 codes that tie into heart failure. There's nothing in place that necessarily maps all those codes to heart failure. So alternatively, instead of searching for each one of those codes, we could just search for individuals that is tied to or mapped to the condition of heart failure.
Well, actually, if you look at this, what you'll see is that many of these broad categories of data are mapped. That's why we use these tree hierarchies, is because actually they do give you that ability to pick things off at a higher level folder. So very good question. If you said, I'm specifically interested in diseases of the circulatory system, and I don't want to look at ischemic heart disease, but I want to look at other forms of heart disease. So if you were looking at like congestive heart failure, we could say, let's search in diagnoses for, or just type in heart failure. So that's a great example. This may help. So I'm looking at heart failure as a diagnosis code. It's going to take a while simply because there's going to be a whole bunch of concepts for heart failure. Now, I could even be more specific. If I search for congestive heart failure, it would narrow it down a little bit. So here we go. Okay. So you see here, there's a lot of heart failure concepts. And notice by looking at the tree, I can kind of see that there are a set of hypertensive heart diseases and heart failures kind of living under the 401 to 405 range. Here, if I'm looking at a rheumatic form of heart failure, it lives underneath the 398 tree. So it really depends on how you want to define heart failure. So this might be the more classic one, is there actually is a higher level concept, 428. So that's a really good point. Sometimes there's going to be a main bucket for things like diabetes mellitus, and then other cases people will mention it in the context of another disease. So they might mention retinopathy in an optic diagnosis concept and say, oh, and by the way, due to diabetes. But in general, if you're looking at kind of the main category of heart failure, from browsing that search list, I saw that actually 428 is kind of the main category for what would be called heart failure, and that's got a population of 27,000 people. So if I was broadly starting with one category, that could be the place I start with. And then I could use defined terms as well as use online resources to say, well, who am I missing by just looking at the main form of heart failure? Is that helpful?
So each one of these has many sub-branches within each one. If you were to choose something very broad, like the HIV example, there's many, many different ones underneath of that. But let's say I want to capture everyone with HIV and I drop that in. How is that going to look on my spreadsheet when I get it? Am I going to have each one of those like billing clinical like as a separate, column or row inside of the flow sheet, or how is that going to affect functions?
So you'll have one row for observation. So yeah, you won't have every modifier attached to each diagnosis because they may be billed for it or may not be in O2. So it's going to be what's attached, what's observed.
Are we going to cover an example of what the data set looks like later?
Right
So
before lunch,
we'll
show you what the data will look like.
But you'll essentially get a single row for each fact, and then you'll be given another table you can reference that shows you the hierarchies that contain that fact that you could use to link and roll up your data.
Right, and you may get to this later too, but kind of going off of that. So this I2B2 tool seems like it's really great for identifying the cohort that you want to extract. Is this also what's used for what we actually pull the data or the data set that we're trying to acquire? So this is our population, but it doesn't necessarily take into account like the variables we like to have.
Oh no, this is, yeah, what you see, this is take all you want but eat all you take. So everything you see in here, if it's a fact in here, you can get it out. So yeah, there are some institutions where they use I2B2 for just cohort definition and counting. We use it actually when you submit your data request. You'll basically use part of the tool to define your cohort. So I want these people, and I want them not to be quitting smoking, and blah, 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 blah. and then you basically just drag in all the stuff you want. So I want not as part of the search criteria, but I want to know what their white blood cell count is.
Those
So,
are for each group, like that's a separate group for each group, like that.
well, I'm stealing Tamara's thunder. You'll put it in a shopping cart. What we do is you save one query that says, here is my population definition. And then in the last group, you just drag in all the stuff you want in your data set. And then what you'll do is you'll get a database back where we'll give you all the raw data, and then we'll also summarize it in REDCap for you so you can browse the data in REDCap case report forms. It's pretty friendly, and yeah, it's kind of interesting. A lot of sites don't fully support that. So you'll get a touch of that in this class.
So for example, if for this patient set of 1 to 88, let's say you're interested to know, okay, I want to know about their tobacco usage. So smoking tobacco, you would pull that in. Or if you wanted to know if they were on a specific medication or what types of medications they were on, you can pull in the medication folders. And you build that shopping cart of the concepts. These first two groups define that patient set that you're interested in, and then the other ones, the third group is what you would get, the type of information you're interested in receiving.
We would just warn you, like an all-you-can-eat buffet,
Yes.
be very careful on overloading your shopping cart, because the more stuff you put in, the more stuff it frustrates Lee, because it takes a while for it. It's not like she has to hand extract the data. She runs a script that will do all the data extraction, but it takes a while. But more importantly, you're going to wind up with all these drugs, and if you really don't want to use them all, you're going to, it's going to slow you down to kind of carve out what you really want to look at. But that, yes, great question.
Yes.
So can I just clarify a little bit more about how to use these with modifiers?
Mm-hmm.
So instead of taking the diagnosis at the top of the folder, you just drag in the blue dot or something.
Correct.
So the blue dot doesn't have a number of facts or patients. I notice when you drag in the blue dots, the number of facts and patients is the same, no matter which blue dot you drag in.
So
Why is that?
correct. So you'll notice each folder as we go down through diagnoses has those modifiers. So we pulled over in that first group the billing modifier for HIV for B20. So it's the total number of facts attached to that B20. But when you do a search, it's going to tell you how many of those 1,382 have a billing diagnosis attached. So the modifiers never have numbers next to them. They're a subset of that number.
On the right into group 1 and group 2, they give you the facts.
Right.
But that's just
Yeah, so you're right, Alan.
Original folder,
Right.
not
You
the
caught us. In a way, we're lazy. If we were really good, we would have also shown you at all the modifier leaves how many facts there are. But we didn't bother coding that up. But yeah, if we were really good, we'd tell you how many modifier leaves there are. So it's kind of like an Easter egg hunt. You'll discover, which ones really are used and which ones aren't. I mean, one of the ones we looked at that's actually interesting is there is a place in Epic. So this principal billing diagnosis, as you saw, that's used a lot by the hospital and the clinic billing systems because that's important to get paid. There is actually a spot that we thought was going to be really exciting where in the EMR, the clinician can say what the principal diagnosis is, or the primary diagnosis. And it's interesting. Now, this may be great for HIV. Actually, that's really good. That's really good. They do a good job of saying, yes, this is the primary diagnosis. Actually, that may also be coming out of Epic billing processes. Let's see how this one does. There's some of these flags where we thought it would be really good, but when you get down and look at it, no one ever uses it in their workful. So some of those flags can be very suspect that we may want to go back and strip out because nobody really uses that flag. Is that helpful? Okay.
Is there some sort of dictionary or something that tells us what all of these things are that I know you have updates every month. So, for example, I'm sort of wondering, well, what's the primary diagnosis? Where would it have been in the EMR that would have clicked that? I can't quite picture in my mind where that is. Is there a dictionary where you can go back and say, this is exactly where we pulled it out of the EMR?
We have it in,
exactly what it's called in the EMR.
So that's a gap we have. Some of this stuff is pretty obvious. Some of it, we got it in the code that does it, or we may have mentioned it in the blog article or ticket, but Tamara has not been on top of things. where we haven't done as good a job inventorying it. So if there are a couple spots where you have those questions, we can probably work to build better libraries of what each item are.
So the problem list there will variously list comorbid conditions depending on what the condition coded.
And that's with HERON, what goes in is what comes out. So how it's coded in is how we get it out. So there is variance in ways of
But
clinicians.
could lead to some breaking up.
So if you look at it from Greg Ader's perspective, the CMIO, it's very important in many cases to update your problem list because that's a great communication from one clinician to the other, and they may not want to go dig into all the billing records associated with that patient. So while, as you saw in some of these, the total number of people that have had some fact about HIV status is, 1,300, if you said, well, how many of those have it listed on their problem list, you'll see that's a subset. And this comes in a couple places that could potentially be, as an informatician, it's kind of interesting because sometimes you want to think about when that data is recorded and up to date. So what's nice about a problem list is if we wanted to build decision support over time to drive behavior or to alert people to something, the fact that the billers code it 3 days after they leave the hospital doesn't do you any good. So, for some recruitment tasks, if you're getting really refined, if you're doing work where you were thinking about recruiting while people were in the hospital, you may want to pay attention to some of that information to know that, well, yes, at the end of the day when the dust settles, they're getting fully codified, but in the heat of the battle of the admission, you may learn that, we don't have a structured concept in the problem list. So those pretty good overview of diagnosis. And like you saw, if we wanted to look for HIV in ICD-9, let's look at that. So this will get you that idea of where's the overlap between ICD-10 and ICD-9, right? So I'm using two different, well, let me go back and fix that. The camera's right. I was grabbing just the ones there. So we'll go back and we'll get rid of that. And we'll go back and we'll grab the whole high-level folder. So how many of these people likely have data that was recorded in the ICD-9 universe that overlaps here? So see, look, almost all of them are the same, right? So to the gentleman's question about, well, when do you use 9 and 10, right? That was kind of the question. What you see here is most of these HIV patients, at least at some point, have had the data recorded in Epic so that it rolls up to either the 9 or the 10 tree. So, if you're trying to get a general estimate, it could be that grabbing them both, gets you, so that was, I think that was 1340, and we noticed that this one was 1382, and this was 1900, and then if I put them both together, I get 1983. Does that make sense? You can kind of see from a Venn diagram perspective, in that case that we just saw.
Yeah, I was about to ask about that. Like, you put them together, but delete the overlapping patients when you actually get the spreadsheet back.
So that's kind of, what you're looking at. What was 1944? And the whole universe was 1980. So it all depends. If you were defining an HIV cohort, you could approach it from either a broad context where you want the whole population we ever have any record of, or you could be in the world where you're saying, I'm looking at recent cases, I might just stick to ICD-10. And you would find as well that this data, if you look at cut it year by year, it might vary. Obviously, there would be no ICD-10 data from the year 2010 because none of the data was coded in that in a true ICD-9 sense. But if it was recorded in Epic, it will appear in the ICD-10 tree because that underlying diagnosis ID still rolls up to an ICD-10 folder. That may be harder to get your head around. Is that helpful?
Yeah. Now, if you take both of them, in the case of HIV, and you pull both ICD-9 and 10, once you get the spreadsheet back, is the overlapping patient going to be report it once or twice?
What you will get is you will get the patient. There's going to be several things you're going to get in your data delivery. One is going to be a patient table that's going to have one row for each patient. But then in terms of looking at the facts of when the diagnosis was reported, you're going to get an individual fact for every time in the workflow somebody coded the diagnosis. So you may see a bunch of facts that say, well, this was an ICD, this was a DXID. What you will see is if it's assigned as a DXID in Epic, one of these diagnosis concepts, it'll only be in there once, and then you can choose to map it to the 9 or the 10 HERON. And if it was billed for as an ICD-9 or ICD-10, you'll see that explicitly as a 9 or 10 code.
So, to the answer, yeah, you could have both. It could be just one, but if they were billed for it and it was recorded in Epic, it's going to be 2 facts. But if it was just billed for it, it'll be 1 fact. It's just, so it comes from the source.
And so maybe to visualize that for you, when you look at these people, so we could do something just to trim this down. If I was going to say, show me people who are female and their race is, kind of the white or African American. And if I run the timeline, and again, the timeline can be your friend to help you visualize the data. What you're going to see on this is a bunch of little tiny tick marks for every single time they're assigning one of these diagnosis codes.
And when you get data, there will be a row for every tick mark. So if you look at the timeline and you got a couple tick marks for patients, you're going to get a couple rows for patients. But if you've got hundreds of tick marks, you're going to be receiving all that data. I mean, there'll be a lot of analysis.
So one thing we probably didn't say, you notice this button here, how we've been clicking that back and forth to open up the views? That's really your very useful tool to change the view. This one, when you do the timeline, boom, lets you take up the full screen. So you can see here, this patient, we had probably record of their birth in 1975, right? Because they're 40 years old. And now when I zoom in, here are all the HIV tick marks. So you can see we first had record of their diagnosis in 2004. That was before the Epic EMR was ever turned on. So that's an IDX billing fact, right? And then you're seeing more and more data being recorded. And then here, this is in 2007. Now it's date shifted into backwards. It's date shifted to March. Remember how we said the data can be sometimes shifted up to a year back? So now what you're seeing is Epic went live. They're one of our patients, and for the first time, maybe they went through the emergency room or went to the hospital, and they had that diagnosis code assigned in the Epic EMR. Notice it's going to be pretty much, if we drilled in on it, and this tool lets me kind of drill in and pan, because I chose in my timeline view the hierarchy of both, the same concept is showing up under both trees. Exactly the same concept. And so I can see that because the folder I chose both the 9 and the 10 folder. I can see, look at that, that's exactly the same fact. Whereas this fact was just recorded under the ICD-9 hierarchy. But as you see, like these people, you're going to get a lot of data because look how many of these diagnosis codes you have. Now this patient, we've only had them come in once. So that visualization, you could also bring in things like the clinical service to get a feel for, well, who is seeing these people? So one might suspect, you may suspect that infectious disease is seeing these people, but you could potentially check. And let me pull that up. That's actually probably a nice thing to show. This is something I find very useful. Is I might go in here and I might say, let me look at if they go to any of the UKP clinics, but I'm going to go ahead and plot the other trees as well, so I can just get a feel for who's a frequent flyer. Who is somebody who has extensive interaction with the KU health system versus not. Now, this may take a while to render because I'm bringing in so many things I'm asking it to plot, but while it's churning, we can ask for more questions.
Did you have a question?
Yeah. Is there a way to kind of determine whether the diagnosis was made internally through KU or if it was reported from an external healthcare system, or a specific type of physician, whether it was like a diagnosis made in neurology or by primary care? Is there a way to refine like that?
That's a great question. Right now, we don't have any external data. Although, when people will record problems on the problem list, they may be recording the fact that the patient is saying, well, I have this, they're passing along information. We do have some past medical history. We now are in possession of Medicare, Medicaid data for 8 states across our Greater Plains Collaborative Initiative. So we're just starting to do work to integrate that data into a new tool that we're calling Grouse. That's going to take data from our EMR systems and blend it with Medicare, Medicaid data. So it's come back in a year, and hopefully we can tell you to use Grouse. But what you can do is when you're building your query, we kind of didn't cover same financial encounter. You can do work where you could say, I want to say this HIV fact was recorded at the same time they visited this clinical service. And this visualization I just did kind of will tell you that. So if we drill back in on this case that we were looking at here up at the top, and we look at their first HIV records, the first HIV fact was here. This was back in 2006. I don't know if this was the same patient or I picked up a different one. Maybe I picked a different one. Okay, but notice they first started visiting us here. They had a visit to MAC, Mid-America Cardiology, on that clinical service tree, and then here in the IDX billing system, they first visited general internal medicine, okay? And then if I get really specific and zoom in so I can see well, I can kind of look at these HIV facts, and I can kind of say, well, when did this one get assigned? That one got assigned when they were here visiting actually on a radiology diagnosis. And this one here looks to me closest to an infectious disease visit. Is that helpful? So just like I did that, I could, to answer your question, I could have said, let me be more specific. Let me go in here and say how many of these people had one of these diagnosis codes assigned at the same time they visited infectious disease. And this will specifically say at a visit where infectious disease billed for it. So normally we've been searching. Is that okay for me?
Go for it.
All right, so I'm talking to you. Anyway, so normally when we've been searching, we've been saying treat independently, which means when you Venn diagram these things together, it's ever in their entire life. But we do know it's kind of tricky sometimes to match financial encounters or visits to the hospital and the clinic together, but we've done a job to try to unify as many things to be in the same encounter. So that feature is going to say, let me know the subset where when these diagnoses facts were recorded, there was also a fact recorded that they visited or had bills generated by infectious disease during the same visit. And that could have potentially been in the context of an ambulatory visit to a clinic, but also if infectious disease billed as a consultant on a hospital service, it may also show up.
Now, this number will probably be higher because he removed the demographic criteria.
And one comment, just point out, did I hit the timeline on this or did I just hit the count? Do you remember?
We made them.
So sometimes if things are working right, you can kick off a query in the background while you spend more time kind of browsing around your view. Although accidentally I hit the timeline to erase out the beautiful timeline I just made. So you get the idea. Is that helpful? All right, back to you.
So following on that same financial encounter, if you're going to use any demographic information, treat that independently because demographic information is not recorded at every encounter. So, for example, this one, let's see, you had females in there. As I pull it into group 3, it still continues to be in the same financial encounter. You can change it here to be treated independently. And this will limit it to a female who had an infectious disease visit with an HIV diagnosis.
Otherwise, what's going to happen? What, Karen?
It usually returns 0. You may get 1 or 2 occasionally.
Because nobody was independently changed gender status because we don't have that data in HERON.
Yes. So does that make sense to everybody? That's running. Let's see. Oh, we were going through We skipped over demographics real fast. There's
Oh, in cardiovascular lab results, probably some of the most useful things in there are, it's organized a little odd in the fact that if the type of modality ever reports that result, it's going to show up under there, so that can kind of confuse people. But if you want to look for ejection fractions and where they're recorded, you could use that data. There's also some really interesting data we've really had nobody look at about device, like if you're into implantable defibrillators or anything, there's some really interesting data there that is kind of available for perusal.
Within demographics, you've got your basic demographics, obviously age, gender, and so on. We also have email on file. If you're wanting to recruit patients via email, you can see if they have an email on file in Epic or IDX. If you want to see a GPC enrollment area, so if they've been visited a clinic here within the past 2 years, you can pull that over as well. An important one is vital status. But before I get to that, we also have MyChart. If you're interested in recruiting through MyChart or limit, some people use this as a way to limit people who are somewhat internet savvy or like to use the internet. We've got distance to KU, vital status. If you've got deceased per O2 as well as the Social Security Administration. So if you're doing any recruitment, you can pull these in and exclude anybody who's deceased.
It's not 100% accurate. So we've had some things we've recruited and people complained, you contacted me and my wife is dead. But at least it helps you a lot because we've picked up, by integrating Social Security, you've got a fair number of people which they think are dead that you no longer would contact.
Right. We went through diagnoses, flow sheets. We've got a lot of nursing data.
Do we have anybody here from nursing? Anybody a nurse? Anybody from physical therapy? Occupational therapy? Respiratory therapy? Okay, there is a lot of really cool data in here. And among the physicians as well, there's some really neat data that certain clinics are now charting, especially neurology we were noticing. So it's kind of the wild, wild west of terminology. So if we were showing you these structured billing codes where, okay, it's a 9 or a 10 and it rolls up in this hierarchy, this data, if you look at our warehouse, it's like half of our database. We've got 1.2 billion facts. Now, some of these are very obvious, like height, weight, BMI, blood pressure, but some of the data that KU Hospital and Health System is recording is really cool. When they build some of these flow sheets, they've got some very, very rich clinical data. There's one giant caveat we'll say, which is when Epic records certain things about lines and drains, we'll know a fact is observed, but we won't know what drain they were talking about. So there's a big pitfall in some of this data where when you're looking at line assessments or drainage, they'll have information about drain output, but you won't know if it came out of a tube or if it came out of a wound. So buyer beware on some of the data, but on other types of data, you may find some really beautiful data. So for example, we had a student taking our class this year who was interested in mental status changes in people with diabetes, but what he found is there's really, I think it was pretty much 2 trees of mental status data that he could really use. It was it in the Alzheimer's Memory Clinic? So for example, the Alzheimer's Memory Clinic is recording on a subset of their patients a mini mental status exam score. So, if you're working with the Alzheimer's group, you may find that, actually, if I'm interested in mental status change, I've got some scores on 1,900 people. How many people are generally working at times with hospital data? Show of hands. Okay. You should all want to work with hospital data because it's so beautiful here. But what's really interesting here, just to trumpet what the hospital does, there is some really interesting data. So the way these are organized is in the EMR, there is a concept of a flow sheet measure. So on these big spreadsheets that nurses would chart by hand, they're called flow sheets. And they will chart an observation that they'll put in what they call a grouper. So you might group blood pressure and oxygen concentration in a little grouper, and then you might put that on a tab or a template called, let's say, vital signs. So we've organized this to where we've done some initial high-level cuts of the data into high-level folders based upon the names of the templates. And then when you start seeing a number after it, that's kind of telling you you're at least at the template level. Now, some of these things, it's so nested that we've gone ahead and said, well, these are sub-folder folders of kind of KUIP, contains a whole bunch of the templates for inpatient activity. So then in here, if you want to know things about some of the inpatient assessments, you'll see some of these flow sheets are built. So at one time they built a grade and pressure assessments. These are kind of like sores in bed. They built a template which has never been used, but this one has been used a whole bunch. So this one has a whole bunch of facts where they're assessing, information about that wound. They come up with a total score for the patient. They have extra input on what's the friction and tearing issues for that wound. So that's really, if you were into pressure ulcers, that could be very exciting. Some of the other data that I think could be very exciting to people is we've had some people in physical therapy research the fact that they have flow sheet information on mobility and range of motion and gait so that they can actually see what the preoperative gait assessment was prior to surgery and then see if that has influence on discharge placement, for example. But some other interesting data that occupational therapy collects, and we may have some students looking at it, is they'll do these initial screenings on home living situations and subjective assessments and objective assessments of the patient's goals. So some of this could be interesting in terms of daily living activities. So if you were looking at outcomes and trying to understand more detail about the status of the patient, that could potentially be very rich data. So if you were working on a surgical process and looking at discharge placement and wondering, will they bounce back to the hospital? How well will they do? Well, what's their bathroom accessibility like? Do they have access to a shower or a tub? Could potentially be interesting. So if you have interest, there is a lot of very rich flow sheet data. In some cases, it can be very specific like that. In other cases, it may be your just more general vital signs of blood pressure recordings and so forth.
How about physiotherapy data collected from outpatients spine center?
Okay.
Does data come into HERON?
So let's look.
My understanding is they use a different EMR.
If they are, we don't have it. So yeah, if they're using, and I know, I think liver transplant has a little liver transplant system, we don't have any of that data. But if it is something where the clinic workflow, so the UKP tree is kind of the clinic tree. So if you're looking at things that are kind of documented in the clinic setting, they'll be under the UKP tree. Now, one thing to keep in mind, kind of like diagnosis codes, they build a single concept flow sheet measure to store this thing. So if there's a measure that's used both inpatient and outpatient, you will see it in both trees. So for example, some of these additional vital signs, like waist circumference, this may be shared between in and outpatient. And height, this is the main height, number 11, that's used all across the EMR. Is that helpful? But you could look at some of this data of the clinic type of information and get a feel for, I don't know, we could look and see if there's explicitly a spine template. I'm not seeing one, but some of these scoring terms could potentially be used by the clinic. Helpful? Okay. Is that about what you need? So what's next? Yes?
Is there a way to find, let's say, members of the same family or something like that? Is there a way to connect to patients who are either in the same household or actually documented to HERON?
Not yet. So actually, we just met. We're going to be partially funded by the Kidrick Intellectual Disability Center. One of the areas we want to pick up is try to figure out if we can tease out the mom-baby linkage relationship. So that's on our honey-do list. So it'd be good to know, if other people are interested, or if somebody was critical to your research and you'd like to pay Marin to change the system to get it, we're always open to work for hire, either written into grants or with departmental support. So those are cases where we try to tell people, if you want that done, we'd love to do it. So that's an example. Trauma, we work with trauma to bring in their registry, and then it benefits the whole campus. But that would be on our list is mom-baby linkage first, and then potentially if there was broad interest, estimates of family. There is one part that's actually in the next folder, which is social history. One part that does have a little bit of family data is when family history is recorded. That is recorded with the lineage. So if you wanted to know things like cancer status, and you were interested in bladder cancer, and you wanted to know do any of these people have a family history of bladder cancer? You could see that of the 4,500 where it's been recorded, 433 have had some positive aspect, and you could say how many have had it directly in their father. But, you know, we wouldn't actually know that the father is Mr. Jones and here's his MRM. Okay. So that's history. That'll give you a feel for what we have in terms of family history. We showed you this tobacco usage. We have a sexually active flag. And that's it for social history. People in Milwaukee have brought in their drinking status and drug use. We may start getting that as well if there was interest. So this is surgical history. I don't know that we've had too many people use this. Do you? This is really a lot of data, but there's spots in the EMR where you can document prior surgeries. So to your question, Alexandria, you know, this would be a place where if they did have hip replacement surgery done out of house, it might be recorded in here because we'd be seeing that someone took the time to document prior surgical history.
So is there a way, other than actually getting into like a clinician's documentation where we can determine, you know, from these spreadsheets, from this view, you know, whether an assessment is either text-based as they're entering it or is discrete? So there are some specific assessments that I'm interested in that I can find on here, but I can't tell if they're entering text or if it's an actual discrete value.
That's a great question. So for people following along, the question is, how could I distinguish between a discrete observation recorded discretely versus text? Everything you see in here is right now, except for when we get to notes, discrete data. So everything, actually, with the exception of some of the flow sheet data, what we've done recently is initially, because we really were sensitive, we always are sensitive to de-identification, we didn't want to bring in free text results because if you just ripped in everything, there could be a free text field called patient's mother's name. And we wouldn't want you to just instantly be able to see in this de-identified warehouse the mother's name. So what we have is most of the data you're seeing is going to be purely discrete data. Now, we will show you, and we have a little bit of work. We have a couple flow sheets left to clean up. Is that right? But we do have some flow sheets first, and we're working on physician notes, where I know this is our test guinea pig. There is a flow sheet where people record where does the patient keep their valuables. So this could be useful if it was real-time data to figure out where you should go take wallets. But anyway. So you can come in here. This flow sheet, normally when you drag in these flow sheet measures, you'll notice that it either just brings it in because it's an atomic fact, or if it's numeric, it's going to prompt you to say, do you want to look at any value, or do you want to say greater than or less than, like the smoking status? But this one is going to be really cool. This is really cool. It's going to say, okay, what do you want to do? It's free text. So I could search this text and say, well, I want to know if they keep them at the bedside. And then it's going to search and find the subset of notes. These are little notes by the nurse that we can let you do initial searches of to see if they contain text. Now, ultimately, we'd love to support rich natural language processing. So if the CTSA Frontiers grant gets renewed, we're going to budget some more time to let you do more sophisticated natural language processing with us. But that's very primitive text searching, and we are in the middle of getting it so that the real golden notes, not that nurses' notes aren't gold, but the notes here under all the physician notes, we're working to do the exact same thing so that you could search a physician note. And don't we have one of the little sets fixed?
No.
But it's depressing because they don't contain any data. They're small. Which ones were they? Remember which one it was? So these notes, this is the stuff you really want. Like you really want us to make sure we got the H&Ps from the ambulatory limit. We are working hard to get those reviewed with the privacy officer of the hospital so that we could let you search an H&P the same way you searched that little note from the nurse. But what you can do right now is with IRB approval, if you want us to give you the notes in their raw form, we can do that now, which is something we couldn't do a year ago. We can now deliver you notes. Although we're a little rough around the edges in terms of how we splice them together for you, but you can at least get your handle on all the notes. So that's.
Did you have a question?
Yeah, so if you want to search the notes, then you go to flow sheets.
Well, no. What I was showing you is there are notes embedded in the nursing flow sheets like that. Where does a patient keep their valuables? And I think if I actually saw that, does it actually display the full text for you in the timeline? Do you know, Tamara?
I'm not testing.
Let's test that out. Let's just check this out. So, oh, did you see what I did there? This is cool. When you save your queries, so all the queries are down here, right? You saw that? I can rename this. I can give it a new name. I can say bedside goodies. And then I can take that query and I could put it in a shared folder. So if I wanted to put this in, let's see if I've got a Rust folder. I could say I'm going to put my bedside goodie query in the Rust folder, and then I'll tell Alexandra that I've got that cool query. But I can also always reuse the query and just drag it in again. And let's see what happens. Let's make sure that's right. That should be right. I will see what happens on the timeline once it kicks off, see if it actually lets you read the full note. But to your question, the notes for the flow sheets of the nurses are in the flow sheets, but all the other big notes are down here in the notes section, the reports section. And right now you can just know that one was recorded, which is a good starting point. Did they do an H&P for this visit that if I requested the data could be useful for me? You can at least get that. I will say right now we're not bringing in certain note types that were recorded externally. So 2 things that will depress you that we don't have yet are pathology notes and radiology. So once we get the free text working, we'll probably go back and try to get the data from external pathology and radiology notes. So let's see. No, it just shows me the text I searched for. So it doesn't show me. How do I check that out? That's I have to look at that field. Oh wait, actually, it does show me the whole note because this one is at bedside. So that's kind of interesting. And this one is bedside. So that field is a text field. So this one says it's on patient bedside table. And this one says it's a watch and glasses at bedside. The clothing is in the closet. So there you go, right? So that's kind of cool. So you are getting to see the full context of that nursing flow sheet note field.
Let's see, we were on history, lab tests. We've got 2 lab folders. One is based on a LOIC national standard hierarchy. Another is the hierarchy here at KUMC. They have roughly the same amount of patients. You can do a test on labs. If there's a value attached with it, as you saw when you drop it into the search, it'll ask you for that value. So you can look for, for example, A1C or greater than or equal to 7.
So I could say how many of these people have a GFR less than 60. So people who have their valuables at the bedside and may have impaired renal function. That could be something you could look at. There are some gotchas here. So we're moving to try to get all our labs coded using this official national standard, so that way you can query our data and query other people around the country. But we have a couple teething pains where the lab system may not have it fully coded right. So if you run into idiosyncrasies where you look for something in the national standard and you don't see it, but you can browse over here and see it, you can always hit the gripe button. Did you show that before?
I did not.
Yeah, so gripe. If you ever want to, you can always gripe. And what it is, it's going to open up a little REDCap survey, and you can give us feedback, or you can give us praise. You can say things were really good. So that's something to show.
Do you think we should start with the LOINC first, or we should do both and do it all?
That's a good question. What do you think, Tamara? I mean, if you're clinical here, in many cases, the way it's organized in the regular folder is going to make more sense to you. But we've had some things where we haven't gotten an updated hierarchy from the hospital for the lab test. So you'll notice there's actually more patients. There are 5,000 more patients up in this folder than in that patient. So I might start with either one. So, for example, we found EGFR under this tree under general chemistry. which, probably makes sense in terms of how you're used to ordering it. The LOINC tree is going to have chemistry, and then it's going to have, let's see here, it's going to be under electrolytes. Where does it put? No, it wouldn't be under electrolytes either. Oh, I'm sorry, you found it. Yeah. So here it is. So it's going to be under renal function and creatinine. And so here, I'm going to get the raw creatinine value, but we may or may not have the eGFR estimates mapped to a LOINC standard. So that would be an example where if you want to look at the raw creatinine value, you could do it here, and you would have it coded using this very precise national terminology. But so here would be probably your main fact. There's the same creatinine, okay? That's exactly the same thing, 2009, that I would find if I navigated under the regular KU tree here. So exactly the same thing, but some of the things that were under this tree, like these estimates, I'd have to search for them to see if they live under the other tree. So that might be something we have to look at.
So in theory, it's the same term, it should be the same, whichever way.
Yeah, let me search. Actually, what I could do is, let's see if this works. I can go into find terms, because I should be able to say, let me find number 191 under the lab tree here. Let's see if it finds that concept, right? So there's eGFR number 191. I'm going to switch it to the LOINC hierarchy, and it doesn't find that one.
Can you search on GFR?
Yeah, so let's look for GFR. So it didn't find it there.
Do you want the numbers in?
No, you got it. I'll get rid of that. Okay, so it has a different place it puts eGFR results, but all these terms, we don't have anything with any facts on it. And if I search for filtration rate, we don't find it. So that's some of the pitfalls of the LOINC tree. We will hopefully get it better, but the value, if you were building a tree using that LOINC hierarchy, is if with our efforts to collaborate with other sites, you wanted to share your query with Southwestern or Omaha, we'd have interoperable data that we could query.
All right, medication data. There's a lot of information within this medication folder. You'll notice that when I open it, modifiers. When I see there's a lot of information specifically with the modifiers, you can limit your search to, for example, an inpatient order or an outpatient order. If you want to know somebody who's got on their home med list, you can pull in historic meds. You can see what's been dispensed, as far as even to how it was dispensed through the MAR record. So if you're interested in that, something that was given via bolus, you can pull this over. So you can make medications as broad as you'd like or as specific as you like. We just recently brought in this SureScripts data. So this is medications that have been filled outside of KUMC. So if they've gone to their local CVS, that will be reported here within the outpatient dispensed. We also have frequency and refill, and this will be on every level of medication. And within medications, as you scroll down into subsets, we've got it by dose. We've got, let's go into central nervous system.
One thing while that's pulling up, I was running that query, and it was using that lab result in conjunction with other stuff. It said, notice it ran for 180 seconds, and then it timed out and it said, I'm going to process this in the background. So you'll notice it still says that, but I can go back and check on the query to see if it's finished. So your query isn't canceled if it takes more than 3 minutes. It's just queued up, and then you can go back and look in the folder down below to see if it finishes.
If you log out, you can see the running before you have to stay logged
It will keep running. So there's a thing called HERON usage, which kind of lets everybody see, is there something running that's taking a really long time? So we'll probably see if we looked at this page, it will probably tell us, Russ's query is, or it's actually logged in as Tamara. Tamara's query is taking a long time. But you can see these prior queries down here. Now Tamara, because she can see everybody, she can see that C. Hester is running an ampicillin peanut query that finished. And she can see that the one we ran is finished as well. And it finished finally, and it was 5,800. And if I went to that little thing, this would show, these class times are always the busiest time for HERON because you have a lot of people in there at the same time using the system. So you can see who's using it, whose queries are taking a long time, and which ones are running quickly.
Okay, so medications. You can see, I'm looking at opioids. You can see we've got it in combinations. It goes down to if you want an oral tablet. Within the oral tablet, it goes down to the dose, or you can get down to the specific. I'm only interested in those with 100 to 500 milligrams tabs, and search on that information. If there is a generic, it'll be listed within that same folder, so you can pull a folder of medications in for your search. When you're dealing with medications, if you're getting data, there's a lot of data associated with it, especially if, for example, your patient set is inpatient. Every time something's dispensed, you'll get a lot of data. So when you're structuring your query with a medication, really think through what parameters you want for that medication. You could restrict it too much sometimes. We had somebody who was looking and they wanted to see what was given, so they went in MAR and pulled over given. And it actually kind of restricted it more than they wanted because some people reported it as bolus, some people reported it as given. So really think through the different combinations of how your medication could be represented.
So let me show you a little bit of that because this is probably an important area. One is this, like remember we were showing you the lunk thing the other time? Here in the case of meds, we're trying to show everything using interoperable national standards, which are a thing called RX norm, and then potentially you'll see NDC codes underneath it. But what you've got is we've then used a standard from the Veterans Administration to organize the meds into different classes. So we're in one of the hairiest classes of all. So there's a class of central nervous system medications, and then a subclass of analgesics, and then you chose opioid analgesics. And this is where you see we have a whole bunch of different modifiers or properties of the drug order that you could look at. Now, some of the drugs that we have in here, the pharmacy formulary has done a very good job of tying it to the national standard, but other things like investigational drugs may not match very well. So Nathan Graham on our team there in the back, raised his hand, has tried really hard. Still, he's failed us. We still have gaps where things don't fully fit into a hierarchy. So I'll just make one comment. There is a high-level category that holds what we call other medication concepts. That is down here. So you'll notice there's 10, we got 300,000 different facts about meds, or 300 million. Of those, we got 10 million we couldn't find a home for. So if you really want to cover it all, you may want to browse that folder or search for the term, because there's some things in here that we didn't find a home for. Now, some of these, actually, after learning about the med mix table from our colleagues in Dallas, we think we have a new plan for how we can get some of these into their proper home, because they're oftentimes compounded in our pharmacy. But in general, that's one caveat you ought to know about. The other thing would be if we're then looking at our drugs like these opioid analgesics, sometimes Nathan is able to place it properly into this combo product of acetaminophen and paroxetine, and other times he may not be able to stick it exactly in the right concept. So this is called this is a national term that is kind of describing that this combination product is given as an oral tablet to be distinguished perhaps from another form that may be given as an injectable. So in general, that's how we're organizing your data. But then it's like you see, you can specifically see for that generic product, there are several different trade names as well as generic names that could be used to describe that product. Is this confusing at all or helpful? So that's something just to pay attention to. One, remember there's that other folder, especially for inpatient piggybacks. You may not see it in the main tree. But if we chain this down, actually, we could test this new feedback information from SureScripts, right?
Correct.
So what's a popular drug? Oxycodone oral capsule, and it's oral tablet. Those are pretty popular items these days from the news I hear. And I could say how many people have the oral tablet at all. We see we've got 82,000 of them. I could look at these modifiers and I could see of those tablets, here's all the things in the formulary that could be used. Now we've never used a lot of those, so it looks like mainly, even though Daziox is a trade name, most of the time our clinicians are choosing the generic name. And Percolone, even though that's a trade name, or Roxicodone, even though sometimes some doctors have said, I'm going to go off formulary and I'm going to prescribe the trade name, most of the time people are prescribing the generic name, and this gives you an idea of what the typical dose is. So it looks like people like to prescribe 30 tabs, and 15 is also pretty popular. Okay, so we could look at some of these. Let's take, this one's really popular, 5, so that's a low dose. That's probably how many of these, we'll just test this. It'll be kind of fun to look at this SureScripts data. So one thing we could look at is how many of those have been written in the inpatient setting. Hopefully we don't have too many queries going on. Because if you wanted to do some work, and maybe oxycodone's not a good example, but I know, so most of these patients have had in the inpatient setting that written. Now that could be written to be administered inpatient, or it could be on discharge. It's being written as a discharge prescription. So it could be interesting to denote, okay, that was written in what Epic thinks is an inpatient. How many of them were PRN? Does anybody not know what PRN means? Everybody knows PRN, don't know it? PRN this is something, you'll see a lot of times the physician may order something, but it's basically per nursing instructions. So it could be, if the pain score of the patient gets over 7, then it's permissible to give them oxycodone. If it gets over 9, maybe you might say give them morphine. So sometimes you'll see orders for things, but you may or may not have, if it's a PRN order, you may not have high confidence that it's been administered. So this gives you an idea of how you could use these combinations to kind of explore how medications are used. So a lot of these patients have had those ordered, but also ordered in their life where it was PRN. But as Tamara said, on the MAR information, unfortunately, as I view it, and even as leadership of the hospital views it, when they built this out, they built out a whole bunch of ways that people can respond to how they address the drug schedule. And so the most obvious one would be, I gave it. But sometimes they may say, I did it per protocol, or I refused it. So we ought to look at this. If people really got into meds, and probably ourselves ought to work with the nursing to kind of organize these better so you can know which ones to choose and have high confidence that it was given. But some of these can be very important if you really get into the meds and you want to get detailed to know, well, did they actually get the drug, and was it something where they tried to give it, but they had to hold it. They weren't able to give it. So, or it was given by their family. So that gives you an idea of how that MAR information could be valuable. And some other things we've now loaded are information about frequencies, so you can see how frequent the med is being given. And then the SureScripts is where?
Patient dispensed.
Okay, this would be really cool. So I may cancel this query just out of interest, but I'm going to be very curious to see, now that we have this SureScripts data, it's going to be very interesting to see how many people can we see where we can get this SureScripts dispensing data. So, we could potentially look at things and say, I'm interested in people who had the drug ordered as an inpatient, and maybe I'm also interested in knowing that it was given as well in an outpatient setting, and I want to know that I have a SureScripts fact that they filled their prescription. Is this interesting? Is this helpful? So you can get very rich in medications. But sometimes if you're mainly just knowing exposure at all, you may just choose without the modifiers a high-level concept.
Good question. When you're like organizing the query into groups, how do you select between the temporal constraint and the treat independently or union? Like what I run, I put into group one like the procedure that I'm interested in, and in group two I put the demographics. But after that, earlier you guys mentioned that you just compile all the variables you want into a single group. Does that like make it a messy spreadsheet at the end, or how would you go about it? Because like the way you have it set up right now, it's like you put the inpatient in group one, the outpatient in group two. Why didn't you put them both together in group one?
Well, part of it doesn't matter, but part of it here is keep in mind every time I put them in a different group, it's intersecting the two things together. So I'm specifically looking at the people who had an inpatient order and have had an outpatient order, right? So notice how my count has gone down. And I now know they had a fill via SureScripts outside our healthcare system. Now, so the business, and we'll talk more later about the shopping cart. The shopping cart is kind of a unique case of just saying, give me all my data. But when you build your query, you can mix and match them in what order you want. But it's very important to keep track of the fact that when these are put in each group, it's always intersecting them. Whereas when you put them in the same grouper, it's ORing them together. Does that make sense? The other comment about the we'll get into temporal, but in terms of same financial encounter versus treat independently, in this example, I'm saying have they ever had an inpatient order for oxycodone? And have they ever in their entire life had an outpatient order? And have they ever in their entire life had the fill? Now, if I change this to same financial encounter, right now I suspect I won't get an answer back because I don't think that the fill data is going to be in the same encounter as the inpatient data. Does that make sense? So you use same financial encounter when you want to make sure those two facts were recorded at the same time. So when I was running the prior query where I was saying I want to know that the doctor ordered oxycodone and I want to know the nurse gave it, that would be an ideal place to use same financial encounter because I may want to know that the MAR, the medication administration record, happened at the same visit where the physician ordered it. But other information like the fill would be something that clearly is not going to happen during the same encounter. Just like Tamara showed, gender, your basic demographics are not variables that are assigned to a specific encounter. So that's exciting just to see that we have some of this SureScripts data. One comment I'll make that depresses me that our team needs to fix is when you run these queries and you include things that have modifiers on them, that timeline tool freaks out and it doesn't work. So the only thing that's really depressing is you'll make some of these really beautiful things and then it'll break on you. But what you can do is you can save the query as a patient list. And what that lets you do is you can quickly use the timeline based on that list and then go rebuild the timeline manually to add in the variables you want to plot.
I guess how you limit the age that you search. Is that also a variable where you now using the navigation that you search by age range?
Yes, you can pull in the age. You can pull, there's two options. There's the current age or there's the age at visit. So if you're doing a pediatric population, you can pull in their age at visit. And if it's in buckets of tenure, and you can pull them over.
So this last query I ran of 4,000 people who've had oxycodone inpatient, outpatient during the same visit, and they had it filled, I could then take that set and use that as a basis of a query. So I could say, instead of rewriting that query, let me take that set and then let me look at people who are in a certain age range, to your point, right? I could say, I'm going to recruit them to a trial, and I want to exclude kids. Or I want to specifically focus in on middle-aged people because I hear that there is a crisis of narcotic use among middle-aged people in the United States. And that's how I would do that. Okay. Microbiology, is there anybody interested in microbiology? I'll skip over this really quick. We have different ways of looking at micro. One way is we have the actual full sensitivity curves when it's reported as being sensitive to particular organisms. You'll see here it's kind of haphazard in terms of what they call everything because oftentimes the terms are not terribly well aligned. But we try as best we can to organize these organisms. So E. coli, we've had positive results on 996 people. They've got a lot of facts associated with them because when you drill down into them, we're reporting that this organism was tested for sensitivity to cefazolin, and you could specifically say, well, how many of them were noted as being resistant? So that could, if you're a micro person, that could be very interesting if you want to look at what positive results are resistant or susceptible to different antibiotics. And this folder, there are some microbiology results, most notably C. diff, where C. diff will be reported as a positive result and it doesn't test for sensitivity. But you can see via different C. diff standards how many are positive. And then you can just get depressed if you're the person in charge of resource utilization. You can see all the times that these tests occur that are negative. So you can see, we're doing a lot of tests for C. diff that wind up being negative results. Yes?
Is there a way to test if you have a lab value that's positive and whether or not they receive treatment for that particular instance of the lab value?
So, for example,
like if someone came back with a high urea nitrogen, did they receive treatment for the UTI or did they not? Is there a way to check that on here? Or?
So you could come in here and say, well, let's look at some of these positive lab results, right? And you could look at a particular type of culture, and you could, in the case of C. diff, if there's some favorite treatments for that, you could build a query and say, I want to see for these positive C. diff results. We actually have specimen source on some of these, but you could bring these in, and then what medication would we be looking for? Yeah, I don't know. Does anybody what? Or see what's a vancomycin? Was vancomycin? Yeah, so we could say, and I'll use maybe the search term here. The medications. So we can see again when I search by term, it shows me all the little subflavors, and I kind of look at the high-level folders to realize that vancomycin. Here's kind of your main vancomycin dosings, the injectable solution and old dosing. I could say how many people had C. diff, and during the same visit they received vancomycin, which could be in an inpatient setting what I might want to do. In an ambulatory setting, I might want to relax that criteria. I might want to use the temporal reasoning to say, let me look for the positive C. diffs and see did they receive vancomycin therapy on or after the positive result. Okay.
We're running over late. We'll go ahead and take a break. We'll be back here at 10:20. We'll finish go over some data. We'll go over temporal queries and look at some raw data as well. All right.
Okay, we're back.
Well, you can probably
All right, hopefully people can hear us again. You want me to finish this off real fast?
Sure, that sounds
Okay,
good.
I'll try to go really quick through the rest of these results instead of talking so much. Anybody with cardiology? There's a folder for the NCDR CAP PCI registry. So all the catheterization data, or if you're a cardiology fan, there's a lot of really rich data about coronary anatomy of the catheterization that's available for you. We've worked with Kamal Gupta on a lot of that work. So if you're interested, work with Kamal and Shravani Shandaka in the back. Shravani, wave your hand. She's our lead person for working on microbiology and cardiology integration. Procedure orders. So for people maybe not totally familiar with clinical workflow, doctors order things and then maybe or maybe not they get done. So when you're looking at orders, you're seeing the intention of the physician to order care. This right now is not matching a national terminology. It's using the local terms here at KU. I'm not sure why it's opening slowly, but this is where you would see things like they ordered a chest x-ray, they ordered a diet order. Right now, it's fairly generic. It's not that specific. I'm going to go ahead. One thing you can do if you're really impatient also is it's okay to open up two folders of HERON at the same time. I don't know why this is spinning so bad, but we'll see. It could be because we got a lot of people using the system. Let's see if this works. Okay, that's weird.
Because we were.
Could be, we may have timed out. So here you see all the different types of categories of orders. So you could see activity orders, admission orders, blood bank orders. So you could see here potentially, various things being ordered from the blood bank, blood transfusions. Did they order a type in screen, and that type of information is all in here. So with the question around immunizations that was brought up before, there may be an immunization section here as I see. Who's an immunization person?
Oh.
Yeah, so we don't have the immunization record integrated. Again, if people are really interested and want to work with us on it, we could, but at least you'll see when the stuff is ordered here, and you may see the medications under the medication section of the administration.
So if you get a search by the financial encounter of an order but not being given, that could indicate
possibly
an exemption?
Could be a starting spot, yeah.
Okay.
Yep, yeah. And then you could use potentially that's another place to keep in mind with HERON. You can look for stuff. We might get you in the ballpark, and then if you had an IRB protocol to do chart review, it could winnow down your search potentially. But that might be a starting spot. So again, there's all your orders. Can be a very useful area. Procedures are billing procedures. So what you'll see in here are, does anybody know what a CPT is? Does somebody not know a CPT? So there's two types of ways, well, let's be gross generalization. People like to get paid, and the doctor gets paid oftentimes separately from the hospital. So if you come in for service at the hospital or a location, you'll see that the act of creating a bed for the person, shooting the x-ray, those are technical charges that are paid to the hospital, and then to pay for the radiologist to interpret the x-ray is called a professional charge. And so what you'll see in HERON is CPT codes reflect the professional charges that various physicians do. Some of them could be the primary attending physician for the admission or the clinic visit, and in other cases it could be a consulting physician. So that patient with the hip replacement is having a lot of professional charges where the orthopedic surgery is being performed. That may be performed in an inpatient setting, in which case it will use ICD-9 and ICD-10. It's a little confusing because mainly you think of those concepts recording a diagnosis, but they're also used to record procedures done in a hospital setting. So if you're looking for things like, did they do a surgery and did they do this specific surgical ICD-10 procedure, you may see it in the procedure folder under ICD-9 and 10. But then a lot of the professional services may be being recorded, especially if they're professional services that are done in an ambulatory setting. They will show up in the CPT folder. So when the pathologist interprets the biopsy, you'll see it in this section. Is that helpful? And again, almost for another discussion to understand all the variability. But that's your procedure data. Red cap. This is legit, right? That everybody can see this?
Yes.
So there is a subset of people, this is just also to tease you, there's a subset of people who have joined a thing we call Pioneers, and they can sign up to be interested in research at KU. And this could really help you if you've got a pre-screening survey you want to deploy and let people sign up for. You can build a survey for pre-screening people for a trial in REDCap, and we can have people sign up on the internet to take your pre-screening survey and be contacted. But this just shows you if you want to have a REDCap project loaded into HERON so that you can use it, we can bring REDCap. How many people, does anybody not know about REDCap? Everybody knows about REDCap? So we've done some really leading work here to let you not only get your data out of HERON and REDCap, but we can actually bring REDCap projects that have MRNs back into HERON. And so this gives you an example. For that Pioneers registry, 439 of them are female. So that's a very powerful feature. So if you are a person who turns on and you have a REDCap project that you want to make HERON enabled, it will show up in HERON, and when you log in, it will ask you, do you want to log into plain Jane HERON that has everybody's stuff in it, or do you want to see a custom version to you that has your REDCap integrated with everything else? So we can create REDCap projects in HERON like this one, where everybody on campus can see them, but we can also, out of the box, set it up so that only you and the people that you assign access rights to in REDCap are allowed to see that REDCap project. So a classic example could be if you're doing mortality and morbidity for your division, and you've got some notes you're tracking in REDCap, you could bring those cases in to HERON, maybe only grant people in your division access to that REDCap project, and use it to then look for lab result changes or other complications. As we commented before, reports are coming out of the notes in EPIC, and they're the notes authored in EPIC. And I'm going to get frustrated again if this thing doesn't kick off. And it's once it opens up, you're going to see two types of things. One is going to be the note, just the types of notes we have, and then over time we're going to have it so you can search them. And then the other thing you're going to see is, has anybody, any physicians in the audience who've used the general note writer tool to write notes where you kind of pick structured concepts at all? Like general, okay. What you'll see if this comes up is that there is a tool in EPIC for writing most ambulatory notes where they'll pick highly structured concepts. And a lot of those physical exam findings will be available for you to search on. It's really, really interesting data. So you can potentially search and see how many people had their wrist examined, and it was denoted as having a problem with it. I don't know if other people are having trouble. Are you able to get in? Let's see here. Just finally coming up on the okay, so let's see if we get in. Okay, so these are visit notes. And what you'll see here is these are all the note types. So this says we've got 39 million notes that potentially you could include in your data set. So right now we can give you these notes, but you can't directly search them except for that's coming. But if you did want to do something where you were looking at a population and you wanted to look at the anesthesia notes in the pre-op evaluation notes, that would be an element you could potentially use, is to say, let me also look at the, get a copy of the pre-op note, for example. The note concepts have all very rich data of all those little elements. While I'm waiting for that to come up, we've got another website we'll introduce later, but this is another way to look at things here. Okay, so here in these note concepts, you'll see that we have, under the EPIC concepts folder, there's over 88 million facts on 400,000 people. some extra family history stuff, but some of the stuff just to show you some things I think could be interesting are, what are the big ones? So there's a big folder for symptoms, and the biggest folder is for findings from things like physical exams. So this is where, if you were looking for a subpopulation with certain cardiovascular findings that you wanted to use to define a cohort in a population. So if you wanted to study people and you wanted to look at their heart sounds, you'll notice that we've got heart sound assessments on about 250,000 people. I'm randomly picking here. If you're looking for the exam findings of do they have a cardiac exam gallop, and you've got 16, there's a cohort of people where that physical exam finding has been found. Pretty neat.
So these are discrete variables in a notes field.
In the note writer. So not every physician uses note writer, but I think a lot of internal medicine, more of the bread and butter family medicine, will use note writer. And if they're using note writer, we have these very highly structured exam findings recorded in this section. Research, recruitment, enrollment. How many people are interested in clinical trials in the hospital? This is really cool. We have loaded every time they update now in Epic that a patient is enrolled in a clinical trial. Now, I'm not sure this is every clinical trial, but it's catching a lot of them. And it's even catching some things where they're using this flag for things like, Alan, you were interested in transplant. I think they're setting some of these flags for the status of like a kidney transplant patient. But you'll see that we have the data on how many people do we think, according to the record, are they denoting as being enrolled in that trial. So that can, and we'll have their status. Are they active? Are they pre-enrolled? Are they inactive? And so this could be really fun. If you're looking and seeing let's say you're the division in nephrology and you're recruiting to clinical trials and you want to see what your batting average is like. You could define a cohort that says, here's who I think is eligible for the trial in HERON, and then I could drag in the research enrollment and see, well, how am I doing? Am I batting 10%? Am I batting 5%? Am I batting 50%? So this also could be a place where you want to use that cohort of people to understand what types of supplemental data in HERON might be available for that population. So that's a new feature.
Yeah, and you can also exclude it in your search. So if you want to recruit, but you don't want somebody who's actively in another study, you can exclude the whole bucket of active enrollment.
Yeah, that's a great example. Yeah. Specimens, this we need to get updated, but this is a dump from Andy Godwin's specimen repository at KU of what type of specimens they have. It's a little bit out of date. Trauma registry has some data brought in for trauma.
We've got some people here from trauma. We just recently brought this registry in, and we're working with them to make sure it's usable, and that's correct. And, so this is an example of how you can bring a registry in from your department.
It's kind of like the trauma, like the cancer registry, but for trauma, and again, benefits other people. So it could create good collaboration for people outside of trauma to work with trauma. Does anybody know about University Health System Consortium or Vizient? A couple people know. Who does not know? Does anybody not know about UHC and Vizient? This is really good data. Okay, so if the data, like the diagnosis stuff out of the EMR and billing, is kind of good data, this is data where we're part of a consortium of other academic medical centers, and we report our billing data to this organization, and then they clean it up and codify it, and then they give it back to us, and we can use that as as attributes for your research definition or retrieval. So, for example, if you were interested in using Joint Commission core measures to define a population, UHC has categorized our data so we can use those criteria. There's the Agency for Healthcare Quality and Research that defines quality standards. So for us to report those standards nationally, we go through UHC. But this could potentially be a good way to cut your population. So if you wanted to look at inpatient mortality according to certain criteria, this data are here. So if you're interested in some of these stroke stratifications that they use for quality definitions, you can see what the denominator population was and then how many patients died. That's more esoteric. The more bread and butter stuff that will be really interesting to you is we have, has anybody heard of a DRG before? Who does not know about a DRG? Okay, a DRG is called a diagnostic related group. And so when you have an inpatient admission, they'll assign, in addition to all the little diagnosis codes, because you'll have multiple diagnoses per visit, they'll kind of say, well, the main reason you're here is for that hip replacement, or because you got hit by a bus. And they'll call it a diagnostic-related group as kind of a high-level roll-up for that main visit. Now, like many things in healthcare, there are different ways they can be called. So there's a Medicare way it's called, there's an all-payer way it's called a DRG, and then UHC has its own stratifications. But you could pick any of them. And what you'll see is, for some people who are into hospital care, the DRG may be the main way they like to look and define their population. So this might be things like, is this a stroke admission where they receive therapy within a certain number of hours? Was this a hip replacement visit? Was this were they mainly here for sepsis? Those are all examples of things in the diagnosis UHC folder, along with comorbidities and complications. And I'll go ahead and pull up another one in case things are slow. Let's see if that popped up. So here you can get a feel for it. So here in the UHC DRG tree, we get to see how many cases came in, abortion, different types of stroke statuses, myocardial infarction statuses, alcohol. Yes?
Only inpatient data?
Yes, this is only inpatient data. Yes. Some other key things are specific UHC procedure data. And this visit details, I want to make sure I catch this before we leave. If you want to know, we de-identify the data, but if you want to know what day of the week, like if you think things happen differently on the weekend, you got that. Where did they come from? What was their point of origin? What was their status for their admission? So was it an emergency admission or was it elective? This is a key one. How long were they in the hospital? And this is how long they were actually in the hospital according to our UHC standard. How long were they in the ICU? And this is UHC does some modeling based upon their diagnosis characteristics that would say they would have estimated according to different standards what the duration would have been. So that's an expected estimate. You can also look up things like what type of physician specialties were involved. And this can be very useful as a proxy for social status. You can look at high-level categorizations of primary and secondary payer status. So if you wanted to look for a Medicare, Medicaid populations, this can be useful too as well. The final folder to show is visit details. This does high-level roll-ups of all the visits for core vital signs like BMI, blood pressure. Now you'll find very dense data back in the flow sheet data, and you'll find a lot of very supplemental things. So things like intracranial pressure or arterial blood pressure will be in the flow sheet documentation, but just a general roll-up of basic vital signs is in this Visit Vitals folder. We also kind of browsed around some of these clinical services categorizations. Discharge disposition status is in here, so if you want to know if we have a discharge disposition for the emergency room and hospitalization, what was it? And then age at visit, this is that concept that if you want to know, using that same financial encounter feature, that this was a child during the visit. So maybe you're looking for people who had antibiotic exposure at less than 2 years old. You might say, okay, I want to look at 0, 1, and 2-year-olds at age of visit, and then throw in this bucket exposure to vancomycin or whatever antibiotic you're interested in.
In that folder also, you'll see a provider. Here we go, provider. If you do a search, it's not going to tell you who that provider is, but you can pull that into your search. It comes from billing. We've got primary care, billing provider, and service provider. If you're interested in recruiting and you want to know who their primary care physician is, so you can contact that physician and reach out to the patient for recruitment. With an approved identified data request, if you pull that into your search, we'll provide that provider name. But in HERON itself, you don't see the actual provider name. You just know that you can get that with an identified request.
Oh, that's cool.
But if,
Yes.
can you grab just a code so that we can see, okay, of 6 providers?
Yeah, no, it's just that provider flag is strictly for the identified data fulfillment.
We could talk about it with the hospital over time, the health system. Right. You know, we could try to de-identify providers, but say it's provider A versus provider B. Right. The only thing you might get a little nervous about is, you know, there are some very small clinical services where you could probably say, boy, if I look at some of these, maybe there's only 2 neuromuscular docs, and if you see A versus B, you can pretty much pick out Mazen Damachki, and he might be embarrassed. You know, so HERON de-identifies predominantly the patient, but you also try to make a somewhat of an effort. That's a pretty good effort to try to de-identify the provider as much as possible as well.
Yes. So sometimes that primary care physician can be incorrect.
Yes.
Do you just find that out when you email the person and say, hey, I want your patient, and they say that's not the patient?
Yeah. I mean, so we pulled the billing information for the provider because we found that sometimes often more accurate because the physician wants to get paid. They're going to make sure it's correct. So, yeah, it can be out of date, but it is it can be out of date, but for the most part, it's billing that's more correct. And there is also, like you see, a difference between primary care and service and. Any other questions? So those are all of the data concepts. So those are all the data concepts. In all honesty, with ITB2, understanding the data and finding that concept that really defines your search takes a little practice. I'm going to go ahead and start talking about how to do a temporal query. I'll also talk about the data request process now. So, right here we've got the treat all groups independently. We talked about the same financial encounter. So we gave some examples of same financial encounter. As was mentioned in here, the length of stay is a big one in the UHC data. By putting a length of stay into your query, you can limit everything that happens within that entire length of stay, that's just by changing it to same financial encounter. So that's very powerful if you're trying to look at, how many sepsis patients, if you're looking at antibiotic exposure, that sort of thing during an inpatient stay. So the other one is to find a sequence of events, and this is where you can do your temporal queries. So I'm going to clear this out. Let me close some of these folders. We've got quite a few open here. I'll do a quick example. So when you, let me just start with a query of I'm interested in people, you know what, for this example, I'm going to stick strictly to ICD-9. When you're dealing with the temporal queries, sometimes they take a little longer to run just because the amount of data they're looking at and trying to look at the timing of it. It can just have patients, it can take a little longer. So I'll try to constrict this one to a smaller patient set. Just for example, within this, I'm going to look at people who have had an AMI. Let me look at ischemic heart disease, acute myocardial infarction. I'll just take this bucket over. There's 12,000, and of those people, I'm going to be interested in how many are female. Let me look at, let me make it, and I'll look even a little smaller here. Let me look at, I'll look at 55 to 65. So let me see how many people I get with this. And this is all treated independently. And so of these people that had an AMI, often people have a hypertension diagnosis beforehand. And I'm going to be interested in how many of these came to the system without, that their first recording was an AMI, that the AMI happened before hypertension. Maybe it's their first time in the system. They came here with an AMI, or maybe they just didn't have hypertension recorded. So there were 927 patients. That's my basic patients that I can work with. So here I have these all treated independently. I'm going to go ahead and switch this to define sequence of events. And I can continue with this. I can add to it. I'm actually going to do a new group, and I'm going to add in, I want to exclude those that were deceased as well. So let me exclude that. And so this is my population. I'm going to go ahead and add an event 1. So I was interested in who came here and had that EMI or the AMI first. So let me pull in AMI into my event 1. Thank you. It's not going to let me. Let me go back to my population. I've got AMI, female. Okay. Let me go back to the event. You know what? It's not going to let me do it. Let me remove this. So this is new functionality. And when we do it through the web interface like this, sometimes it doesn't like it. Let me try reloading. Nathan, do you have I may have. Oh, that's right. He had a couple of these open. Let me close some of these. I think it's gotten too many open at once. So there's this thing in here, and if you sit unused, I can't remember how long it is. It'll automatically start logging you out, and a little pop-up sign will say, "Do you want to log out? Yes or no?" I always say yes, log out and re-enter, even though it gives you the option. You need to log out and re-enter. And I had a couple HERON items open at once, and it was like, okay, that's enough. You need to log out, re-enter. Okay, so here's my patient set again. I'll stick with the 927 for the the AMI, female, 55 to 64. I'll leave the deceased off for now. I'm going to go down to define sequence of events, event 1, and diagnosis. There we go. So my event 1 is an AMI. I'm going to go into my event 2, and I'm going to make that hypertensive disease. This folder has quite a bit. I'm just going to pull the whole folder over. And it doesn't matter to me if it's 401 or 405. That's my event 2. Now, as you can see, there's multiple groups. You can make these events as detailed as you want or as simple as you want. So I could be adding things. Maybe I want hypertension and a certain medication or length of stay. But I'm going to keep it just with the AMI for the first event. Second event is hypertension. So here you can define your order. So I want the start of my first event, which is the first ever AMI, to occur before the start of my second event. You have options to change this. It could be on or before. It could be after. It could be at the same time as. You can change this to have event 2 go first versus event 1. But I'm going to keep it with the same straight. The AMI occurs before the hypertension, and I'm going to say by greater than or equal to, I'm going to say greater than. I'm going to say 1 month. You can go by days, you can go by years, you can go by months. So I'm going to see how many of those had an AMI recorded, and then a month later had hypertension recorded. And these are limited to females 45 to 55, I believe. So while this is running, you can see at the bottom here you have an option to add another relationship. So you can keep adding multiple events. You could say event 1 happened before event 2, add another relationship where event 2 happened before event 3, or event 1 happened before event 3. And once you add a relationship, you can also remove a relationship. So sometimes you'll get it in there and it's not going to be what you expected. You can remove that relationship. Now, one thing with these temporal queries, they're very powerful. They really help you define that patient set. So you can see 57 people had the AMI recorded a month before any type of hypertension diagnosis. One thing about these temporal queries is, like I said, they're very powerful. They can really help you narrow in on that patient set, but make sure if you're using more than one constraint that you really think through that logic, because sometimes it's easy to, if you got multiple events, say 1 happens before 2, 2 happens before 3, 3 happens after 1. That logic isn't going to quite work, so you're going to get 0. Yes?
The example I was asked to do a while back, where we had event, results, and we want repeating. They were asking dose adjustments based off lab data. So similar thing, but in a much tighter single financial encounter,
yes,
multiple times within the same day.
is there actually a way to get a timeline in that short of a time constraint that's fairly clean without?
So let me see if I've got this correct.
I understand, typically like these, we're looking at overtime.
Mm-hmm. So you were looking for, say, like an inpatient stay happen sometimes within a day or within a week. Change. So they have a lab, a medication, another lab, and then they may adjust that medication based on the. Okay. So you can get down to the hour, days, but when you're looking at that type of data, I would suggest getting the raw data and analyzing it.
That's what we're about to do.
Yes.
There was no simple way to try to get a timeline. So.
Right, because and sometimes but of course I'm very familiar. I like getting in there, writing some SQL and getting the data. I want to see how that data changes visually. Things could be getting. You can't see the logic behind this. In theory, you can, but when you're looking at that close of time, I would get the data itself. If you're looking at months, I think it's easy to use this to define that patient set. And even if you use this to define that patient set, you get that data. You can still look at the data, make sure. One thing, let me run this again. I'm going to click the timeline for this one. Because whenever I use a temporal query, I always use the timeline as well, just to make sure that I've got it set up like I expect it to. So I should see when this timeline comes up, patients that have an AMI that happened at least a month before that hypertension diagnosis. And if for some reason a hypertension happens before, then I didn't get that query set up correctly. It takes a little longer for the timeline. But does anybody have any questions about that temporal and option functionality? It's really powerful in narrowing down that patient set. But when you get that data, if you do a data request, you're going to get more than just that narrowed down. So for your example, maybe it's infectious disease, you've got a lab, a medication, a lab, a medication, and then maybe they get an outpatient order and they get medications that continue on for a couple years. When you get that data, you're not just going to get that window of that stay. You're going to get all the data every time this medication occurred for this person. So if it's something, like a cholesterol medication, you could get a lot of instances of this medication. So that's something to keep in mind. Even though you're limiting your patient set in this interface, you're not necessarily, when you receive that data, it's not going to be limited as well. You're going to have to do some cleanup of the data. So this should be coming up. And when I run the temporal queries, you can see here there's a little T that shows up in front of it. That's to tell me that it is a temporal query. I guess it does take a little bit longer. While that is going, let's see. So we've gone through the data types. We've gone through the same financial encounter. We've gone through doing a basic search, modifiers. I'll go through another analysis. We've talked about the timeline. That's an analysis tool that helps you visualize your data. There's also an analysis tool called the demographic tool, which I'll show you, that gives you a demographic breakdown of your patient set. I'll wait just a few more minutes and then I may give up on this one. That one's going to be, you know what, I will go ahead and continue with the analysis. Let's see, let me find a patient set. So to use the analysis tools, you need a patient set. Where am I? Let me see some of mine. This one, let me try another one. Oh, there we go. As soon as I can log into another one. Here we go. So you can see this was the AMI happened a month, or that's the female, I'm sorry. The AMI happened before the hypertension diagnosis. Now in this case down here, it did not. And as I pan out a little bit, zoom out a little bit, you'll be able to see that, in fact, the AMI did happen prior to the hypertension diagnosis. So this is a way to visually look and see, is my search acting like I expect it to? And this is a good way to make sure it's acting as you expect it to prior to getting the data as well. So let me get back in here and see if I have a patient list. So when we ran the search, you saw that there's an option to do a patient list. You really don't see any difference in the interface when you get a patient list. You still get just a number of patients. What that patient list does is in the background, it creates a list of patient numbers that you can use with the analysis tools. Let me see. So it's great that I can see everybody's queries, because if you have any questions, you can call us. I can pull your query up and help you go through it. But the downside is I can see everybody's queries, so I want to see one of my previous ones. I have to go back a little further. Well, I'll come back and show you the demographic one in a second. Let me get into HERON. So see how that one, it says, okay, log out. Always log out, because it just tricks you, and it says, okay, you can remain, but I'm not going to work properly. So let me get into a new one. So I will come back and show you the demographic tool, but before I do that, I wanted to talk a little bit about requesting data. So when you do a HERON search, you get a number of patients, and that's pretty much it. You can see some stuff in the timeline to see the timing of events within their record, but you don't really get the start date, the end date, the lab value, provider name if you're interested in an identified data. So to get that information, you'll need to do a data request. There's two types of data requests you can do to get data out of HERON. And it only shows up for faculty members. The only people that can actually request the data are faculty members. So if you're not a faculty member, you're collaborating with somebody who is, you'll need to get them to submit the data request. So under investigator resources, there's three options. They can submit a sponsorship request. So if you're not a faculty member, you also need to be sponsored and everybody here is either faculty or sponsored. But if you have somebody that's not sponsored and you're a faculty member, you can click here, add them, request sponsorship for them to be able to search HERON. The other two are the data usage request and the RRC, Frontiers Participant Registry request. So those are kind of vague kind of terms that are kind of confusing. But what this means is the data usage request is getting that raw data. So when you do that, it goes through a committee called the Data Request Oversight Committee, which is comprised of members from the hospital, the medical center, physicians, somebody representing the physicians as well. And it's just they review any request and approve or deny it. You do not get any patient contact information. You would get, if it's an identified data request, an MRN. You could get a birth date, a death date. You can get any of the information that you're requesting through your query. Let me go ahead and click on that. So here, when you click on it, you get a, I'm gonna act like I'm doing a data request, and I will have Marin on there as well. So here I'm going to add her. If you have an IRB and you want to, you can put in your IRB number and it'll bring up everybody on your study, and you can just start clicking yes, 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 I want this person on there. I will also add Lee Wong. Okay, so I've got two people I want. This is great. I don't want to remove anybody, so I'm going to go ahead and say I'm done choosing people. It's going to drop me in here, and I'm going to have to add a title for my research, as well as if there's an expiration date. This is mostly useful if you've got somebody who you want to sponsor. So if you're working with a student on a project for a semester, you could say 6 months. If you're working with somebody, you want them to only have access the data until July. You can put in an expiration date there as well. The purpose of this request is a data use. And this is our data use agreement. And this is basically saying, this is patient data. You are going to treat it as patient data. You're responsible for the members on your study team. Don't try to identify people. Don't do anything wrong, bad with the data. You're going to give a description of your data. This can be as detailed as you'd like, or it can be a higher level description. It needs to be more than just, I want to recruit patients. Some idea of the topic, the study inclusion criteria. And it can be an umbrella description, because sometimes you will request data, you'll get that data, and you'll think, oh no, actually this is wrong. I need to change this. I need new concepts. I need less concepts. So this approval will allow you to get multiple data requests, but it's got to be within that description. We ask how you're going to use this data. Some people use it to narrow down that patient set to do a chart review. People want to do a publication. If there is a publication, we ask that you, the hospital wants to know anytime we're being represented out in the world. Patient recruitment gives you a little more information about the Frontiers process. I'll go through that one next. If you're asking for identified data, we want to know if it's research or quality improvement. If it's research, you'll need an approved IRB. And so you cannot actually submit this until you have an approved IRB in hand. If it's quality, we ask for a QI letter of determination, which also comes from the HSC group. I don't know if anybody's doing quality work here, but you'll need to also address these questions. And if it's de-identified, you don't need to attach any additional documents. You always have the option to, especially if you have like an involved search criteria. Sometimes it's good to attach it so the group can see what type of information you're looking for. If you've already done your search, we ask that you put the same search name, because once it gets approved, we'll pull that search name and start pulling that data for you. Usually we contact you and say, okay, is this the correct one? We'll start pulling it. And then we ask if people are requesting data that contains any of the free text notes information. So we just recently brought this in, as Russ had mentioned. And one of the things that we want to make sure is that people aren't studying provider behavior. And if you are studying provider behavior, that's okay, but you'll just need to have an IRB for that study as well. So on here, we've got the users that I mentioned. So Maren, I would say, yes, she's an employee. Lee, yes, she's an employee. Or if not, let's say Lee isn't, I could say, she's a student at the medical center, or list their affiliation. Again, this is just to let the administration know who's using the data and how they're accessing it. If you do have an IRB and it's an approved for identified data, make sure these people are on your IRB, because if they are not, it will not get approved. You'll have to submit an IRB modification. So make sure before requesting any identified data, I mean, you can still request it, it's just going to get held up if everybody's not on that IRB. Because members of the request committee are members of the HSC as well. And then you click submit, and usually you get a response within a week, whether it's approved or not. Once it's approved, we can start running the data for you. Yes?
When you order identified data, you give us the medical record number as well, or how does that work?
For identified data, you'll get the medical record number. You'll get demographic data out of the box as well. I'll show you that in a few minutes. But like I said, you don't get any name, address, any of that type of contact information. If you are wanting to recruit patients, there is, let me go back to HERON. Identified and de-identified.
Okay, so you don't have to add it in the query?
No, the only one you have to add in your query, unfortunately, is ethnicity. For some reason, that isn't. It was just the way it was structured in the EMR. It's not part of the demographic. But we will fix that one of these days. But that is the only thing that you need to pull in. So the Frontiers Participant Registry request, this is if you're wanting to contact the patients for recruitment. And this form's a little bit more involved. It tells you up front what you need, the protocol, the approval letter, the consent forms. It's similar. You'll have to enter your name, department, all that good stuff, phone number, mail stop. It's wanting to know principal investigator, alternate contact if there's a project coordinator. The required documents are the HSC documents, approved letter of notification, the protocol. And if you are the physician, if not, they ask that you have a letter to that physician to let the physician know that you're going to be contacting their patients. And then the name of your HERON data set. And this one's more involved. It wants a little more information about your search. And then once it's submitted, it goes to a committee that's comprised of faculty members on the medical side, hospital privacy officials, as well as human subjects committee as well. And they review this. The turnaround is very similar. The person that's in charge of this Frontiers registry that you'll be interacting, her name's Barb Shull. She'll help you with your query, make sure everything's in order. And then once approved, you will provide that contact information, but it's strictly name, address, phone number, email address if available. And that's pretty much it. You don't get any information out of that patient's record. If it's a parent, if it's a child, we provide parent name. Is that correct? Do you remember? I don't remember. If there's a child, there will be a special a flag in there as well. So those are the two types of data requests. Yes. Mm-hmm.
So if you get identified data, do you give the real dates or the fake dates?
The real dates. So the identified data is the real date. That is, if you do the de-identified request, it's the de-identified dates. So within the identified data set, you'll get the real dates, you'll get the MRN. You will get, there is something in there called a patient number. That's a de-identified number that's attached to that patient. That's the only thing that would really be de-identified.
Does that number get changed? Or does it stay with the person? If you do a second,
the patient number,
that patient shows back up. Is that patient number different?
Yes. Well, it depends on when you do your data request. So every time we have a release, we de-identify the data. So like I said, dates are shifted up to 365 days in the past, and that's going to happen every release. We try to release monthly so that you have data up to date to the end of the previous month. So I could be shifted back 90 days this month, and then the next release I could be shifted back 120. And then the release after that I could be shifted back 9. And that patient number changes also with each release. If you get identified data, obviously the MRN is the same, but that patient number changes with each release. So if you're working with de-identified data and you pull data in February and you decide, oh, I want another patient set, you pull it again in March, or let's say May. You're going to have different dates and different patient numbers, and it's going to be very difficult to tie the two together. You're going to have to just start analysis from the beginning on that. So, did you have a question in the back?
Yeah. Do you have any suggestions on how we deal with seasonality? Data shifts so large.
Seasonality is difficult with the de-identified data. The only way to really deal with it is to get the identified data. Yeah, so if you're doing like any kind of seasonal allergy research, it's very difficult to pinpoint with the de-identified data.
But that could be through as a quality project, not necessarily research, correct? For identified data.
Right, you could do quality, as long as you get that QA letter of determination and stuff.
I couldn't hear the docs question clearly. You said the identified data doesn't have the date.
Correct. The identified data has the actual dates, not the date shifted dates. Any other questions? So once your data request is approved, if you have if you went through Frontiers and you want that contact information, you'll receive a spreadsheet through Secure Files that has that name, address, phone number, email. That is it. If you are trying to do some data analysis and you go through the Data Request Oversight Committee, we'll supply that data in a REDCap format. We'll also attach the raw data to it as well. So let me show you an example. One thing to note, so when you do a search, you can search, you can create patient sets, and Russ showed you an example of pulling it into your search. Since patient numbers change every month, if you pull a patient set into your search, 2 months later, your patient set could be different. So my point is rerun your searches with the new releases, if you're going to be pulling patient sets or searches into different searches. So in Shared, I created an example. Okay, and in this example, this was one we actually had a little while ago. They were looking for patients who had sepsis, septic shock. I limited the dates just to get a smaller patient set for this example to January 1st, 2014 to present. They were interested in those that had lactic acid values, and they had default values of greater than or equal to 4, greater than or equal to 4. And then they also were interested in any O2 saturation. And they didn't care what the value was. They just wanted them to have this. They were interested to know if they were deceased, if there was cortisol, free serum cortisol. So this all occurs within the same financial encounter. You'll notice I changed the dates to 1. Because this is the same financial encounter, it's going to apply to all of them. But if you're treating things independently, if you apply the date constraint to one group, don't assume it's against all the groups. So you would have to change it for each group. And that's important to note when you're dealing with the demographics also. You don't want to limit your demographic to a date because it could have been 10 years. That demographic information could be reported 10 years prior to their visit to the hospital. And real quickly, one thing I didn't point out earlier, which might be of value to some people, there's an occur greater than. So this, if you're interested in those that had, for example, sepsis occurring more than once, it's probably going to happen more than once. But if you've got a certain, if you're interested in things happening, if they're not, you want somebody, for the AMI example, they had to have more than one heart attack. It had to happen, you could occur more than once. If you have, there's a caveat to that, if you have multiple items within a group, it can occur more than once. So this person could have, in this example, a sepsis or septic shock. They could have 2 occurrences of sepsis, or they could have 2 occurrences of septic shock, or they could have one of the sepsis or one of the septic shock, but they had to have multiple occurrences of it. Change that back to 0. Okay, so this is the example. Another thing I wanted to show you is, I'm not sure if that'll work. It won't work since I didn't run it. Let me run it. There is, I'm going through and showing you visually through each group, and sometimes it's hard to read because there's these little boxes that say 1 or more, or none of these, or there is also a print query. If you pull, it'll print out all the items within your query. So you can look over and read it. That's sometimes helpful when you're sharing queries, especially when you get involved, because I've had some queries come through that are like 8 groups and there's hundreds of concepts, and you can't really visually go through in these little boxes and read it. I've had some that took 3 days to run. They were that involved. So 581 patients. If I do this print query, let's see if it'll pop up. It's thinking. While that's thinking, so these are the items. The way they define their patient set is they were interested in those with sepsis or septic shock, who had a lactic acid reading. Here's the query report. It will list out each one. I hope you read that query. And then they wanted all these additional elements. So in this, when you do a HERON search and you ask for data, you're going to get everything in your search, plus some demographic information. So I ran this query, and I ran the data. Let me go to our REDCap database. Whenever you get data, we always start it with DUA. So if you have any REDCap projects with a DUA, that's a data request. This is, you'll notice this list of forms are each related to the folders that that information came out of. So in this query, we had some diagnoses. This deceased is from demographics. We had labs, and you can see each of those folders represented over here. So in this example, we've got 581 patients, just like the search had recorded. I'm going to look at the first one, and this is this patient number is that de-identified number that changes with each release, but you can use it within the same release. This person is, yes, they are deceased, and again, this is the de-identified date-shifted dates. Out of the box for all of your query patients, you will have the birth date, death date if they are deceased, their age. If you're doing any type of data analysis, you're not going to want to use the age. You're going to want to calculate on your own, because if you get this data set 6 months ago, that age could change. So make sure you always use that actual birth date when doing the analysis. Gender, language, we've got race, marital status, and religion. Those are basic. You'll get all those with every patient. Demographic, this person asked also for deceased, not knowing that it was in the patient form anyway. But you can get, if you were asking for ethnicity, this is where you would find it, or some of the other items, like if they had an email on file, it would be here, or distance to KU, that type of information would show up in this demographic form. The diagnoses, you've got this person had sepsis and septic shock, both diagnoses. So this person had the diagnosis 4 times. It shows you that first date and that last date. And it also shows you that last modifier. So this was a billing diagnosis the last time it was recorded. Same with the septic shock. We've got the lab tests. And you can see not everything is filled out for every patient, but this patient had this lactic acid 5 times, cortisol 3 times. So for this lactic acid, it's 5 times, first date, last date. So this is 5 times within a day. And it shows you the last value associated with that, as well as the modifier. So REDCap is good because it gets that information together. And if you're wanting to do some high-level analysis of, how many patients with septic shock had a lactic acid syringe, 2016, you can do numbers in that way. But if you want to know what was the variance in the value associated with that lactic acid, you're not going to get that in in REDCap. Because each research question is different. We just kind of made a standard assumption. Okay, we're going to guess people want the last value associated with it. So here, REDCap only displays that last value. Let me try a different. Yes.
You have the parameter set to greater than or equal to 4 online.
I did, and that was lower. Correct. So that's a very good question. When we provide the data, we're going to provide all the data for that person. So you say you want lactic acid. Okay, here's their lactic acid across the entire spectrum of the EMR. Again, we don't know exactly what your research question is. You may only want those lactic acid values in that time range, or you may want, let's say they were admitted, you want future follow-up values. We don't know exactly what your question is, so it's up to you to go in and cut down that data to what you're interested in. And so in that one example that that person had a 3.3, It's less than 4. But at some point they had a 4, and they had 5 values within that one day. So one of those went up to 5, or was over 4, and then it probably dropped down at the last recorded one. So yes.
So I had a question about how to put together a search when we do a request.
Mm-hmm.
So we're searching for certain concepts to put together the patient set. Each of those concepts you're going to provide the data on. And then if we want other things on that, we're supposed to add it to another group.
Correct.
How do you want us to put that together?
So let me go back to that query here. So here they were defining with with sepsis, septic shock, and lactic acid. They had to occur within the same financial encounter. So that limited our patient set. And then these were the additional items they wanted on that patient set as well.
That's an and.
Correct.
So if there were patients that had sepsis and lactic acidosis, but they had none of the labs on the right, you wouldn't show any data on that?
Correct. So this person knew that they wanted that we would have had either the O2 or, let's see, what was it? I'm trying to remember the logic behind this example, but they knew that it wouldn't exclude any of the patients that they were interested in. A way around that issue that you're discussing is you can pull in gender, because everybody's got a gender associated with them. So even if I pull in gender into this query, I will come back with that same number because everybody's got a gender.
But I don't need to repeat sepsis.
No, you do not need to. So did everybody understand that, like, workaround and that question? Yes.
One thing I found out working with Lee one day that I didn't even think about. It was actually easier to think on one part in exclusion versus inclusion. I was trying to add people in, she was allowed to just exclude the few that she wanted.
Excluded?
Oh, that was a simple way to think about it.
Right. Yes, and that's.
And it did help speed it up too.
That does help, yeah. I mean, especially like I think there was an example earlier today. Instead of pulling over every folder from 18 and on, just pull over less than 17 and exclude if you're wanting an adult population. So there are ways to exclude. Okay, so back to this REDCap project. So I've shown you they've got diagnoses, labs. Some of them had demographics. I want to show you some of the stats and reports. Let me look at. So another reason we bring it into REDCap is this gives you a little high-level visual stuff. Like you can see how many are missing. 0% were missing the vital status. Looks like the majority of these people, unfortunately, are deceased, 331 versus 228. This little @ sign here, you'll see in your data sometimes, that's unknown. Sometimes there's data elements that are missing when you're dealing with this much data. You can see how many age. It shows you the minimum, the maximum, the mean, all that good stuff. And you can hover over to get specific items, specific numbers. And also show you sometimes you'll see an aberration. Maybe there's one that's 300 years old. I've seen that before where there was a birth date that was incorrect. But for the most part, it's clustered around the same age. Looks like this is more common in males than females. It breaks down the language, race, marital status. The majority of these people were married, and then religion. You can also look at, for example, the labs. Again, you can look at this information however you want, but this gives you that high-level overview of, where the median is for values. This is only the last value because we made that assumption that you're only interested in that last value. If you want to look at all the value, you've got to go to the raw data. So let me show you the raw data. So with this REDCap project, you do have that high-level limited view of that data. With some people, this is enough to get all the analysis they need done. Some others need to do a little more. And in the file repository, we always add the raw data. And sometimes the raw data is too big to add. We'll send it to you via secure files. So with each data request, you'll get variable data, patients, the actual data, and code information. Let me bring up a little overview of that. That data. And I believe you received a handout which gives you links to many of these sites that I'm bringing up today. So there is a HERON data set page that we have that explains kind of how the data is presented. So in the patient table, you'll get these. This is back to that same. This is going to be just like what you find in REDCap in that patient form. It's going to have the number, the vital status, the birth date, the death date if there is one. And this page also defines what you're looking at. So under marital status, sometimes this one's a little confusing. Sometimes people ask me, what does X mean? That means they're separated. You'll have a variable table, and this will every variable you have in your query will show up here, and it'll show you this path as well as the name and the tooltips when you hover over what it says. This gives you a little more information about that as well. The data table, it'll have the number, which is de-identified, the encounter number, which is also de-identified, a variable, the val type. This one's an N, so it's numeric, and it'll have the value here. This is a code. It'll have your code here. It's going to have what the code name is, the label, a modifier if a modifier is present. So this will be helpful when you're dealing with those, when we were discussing earlier the diagnoses or the medications. The medications have a lot of different modifiers that could be attributed. And you'll be able to tell in here, okay, this was an outpatient order that was ordered on a certain date. So this modifier is kind of gibberish. It's you know, how it's in the database, but this is what you see in the system. So it's a little more friendly terminology. There's an instance number which is de-identified, and you've got the start date and the end date as well. And again, this will go into a little more information. If that T-val up here, we had the, there was a numeric, and I'll always have a number here. If it's code, there's a code. If there's a T, it's text. The text will be associated with it as well, for the notes, that is. And then for identified data, you also get the MRN field. And then the code info has the code name as well as the label. So this is like, I have no idea what that code means, but I do know what glucose is. So that 2010. It's got the tooltips, the path, and again, this little information. So you may be wondering why you need that variable or why you need that code, because they're in your data set. Why would you need it? These are helpful if you're trying to do a search, or if you're analyzing your data. If you know an ICD-9, that's easy. You can, you know, select. You can within SAS or SQL or something. You can select just that specific ICD-9. But let's say you're looking for a range of ICD-9s, and you pulled in the folder for ICD-9 10 through 15. You can pull that path over and help limit to multiple items. So it takes a little practice, but they're useful when you're doing your data analysis. So let me actually download and show you what the data will look like. I'll start with the patient data, demographics. And this is how it will appear. And the patient table is one row per patient. And it's got your vital status. It's got everything that you saw in that that REDCap form. This is pretty easy to analyze. Then you've got, let me show you that variable table. This is the one that has that path. So you can see an example of what I was trying to say. If you're looking for all these cortisols, so with the data set this small, it's pretty easy. You could just say, okay, I'm looking for these 3 cortisols. But sometimes some searches may have hundreds and hundreds of concepts, and it's frustrating to have to list each one independently. You could limit just to this path, maybe through endocrine 4 or 4-endocrine. And then that would pull up with the star at the end, that would pull up everything within that path. Let me go to, the code info is very similar to that variable data. See if it's going to open. It's a variable. There we go. Code. As you can see, there's a lot of codes just for the septic shock itself. So we just pulled in that sepsis, but as you can see, there's quite a few within those folders. And it's also got the modifiers at the end as well. So this will be useful if you're doing any type of analysis through a SAS or SPSS. De-identified data. So this is what everybody's really interested in, is the actual data. So when you receive the data, it looks like this. And right now it is, looks like it is by code. These are all vital status. Okay. Looking at this, I'm not as interested in vital status as I am the other stuff. So I'm going to sort this. I'm going to sort it by, I'm interested to see what happens to the patients at an encounter level, because these are inpatient patients who have sepsis, and I want to see how their encounter went. So let me add the encounter. So first I'm sorting by patient and then encounter within, because some of these patients come back and have multiple encounters. So you can see with this one, patient 4492, they have, within this one encounter, 22 lines of data. Actually, let me go down to the bottom here. So for those 500 patients, 581 patients, there's 27,393 observations that you'll be wading through. So my suggestion is sometimes it's easier to use a statistical analysis tool. So trying to go through line by line 27,000 patients in Excel is not going to be very easy. So my point in bringing that up is that this query is not that many concepts, and it's on a small patient set, 500 and some patients, and it produced over 27,000 rows of observations. So like was mentioned earlier, take as much as you want, but eat what you take. You're going to be aware of, you're going to have a lot of data analysis to analyze the more you put into your search. So in this query, or in this data set for patient, let me go back up to the top. So for patient 4992, you can see these first ones here are the ICD-9s. These are the diagnoses. It shows you when they were, the diagnosis occurred. What I'm more interested in is the labs. So we can see here, this, as I scroll over, it's too much to fit on one screen. But these are the lactic acid, the cortisols. You can see the lactic acid labs here. We had a 5.1, a 3.32. So I believe this is the example where it was a 3.3. You can see at one point it did spike above. So in the beginning it spiked at 5.1 and then it went down. So they did meet that criteria, but you're getting more information than just that one lab value. So this is where you would use it to analyze, trends over their stay. If something changed after certain medication was introduced. This is where you can really do that temporal analysis with the data. We've got, so this is all one stay for 22 rows here. You can see how stuff has changed over time. It looks like most of this happened in September 12th of 2014. This is the de-identified. You see the next one. Oh, and unfortunately, it looks like they passed away on September 12th as well. This one here has, this one here, you can see this one is an encounter number, and then they had a second encounter. And so they were here in 2009, they came back again in 2014. Had quite a few items. So this is what's called a long skinny. There's one observation per row. So a lot of times when people want data, they expect it to be one row per patient. So you think, okay, I'm going to have patient 1. This was their date of diagnosis. This was their lactic acid. This was their cortisol. But in reality, there's multiple values, and we don't know exactly what you want. That first, the last, the median. So we give you the data and let you analyze it as you like. Does anybody? Yes.
I typically always not taking the loop.
We don't. Yeah, we don't have, because some things produce a lot of data. We've had to cut searches into a couple different searches and send a couple files if they're too large. If often they're too large to attach to these REDCap projects, we send it through secure files. There is not a limit, but if you're going to get a large file, I strongly suggest you use certain software to open it, because if Excel will crash with certain sizes. I don't know, does anybody here heard of use SAS or SPSS? Okay. Is anybody familiar with SQL? Okay. SQL is a great way to get in here and quickly cut down your data to import it in SAS. You can import these CSV files in SAS and do manipulation in there as well. But I always prefer SQL. It's easier for me to quickly get in there.
Do you know if R handles these data sets
Yes.
pretty well?
You're an R user? Does anybody else here use R? Okay. R is great. Yeah, in fact, we try to use that in our group. It's not as common at this institution, but yeah, we've used it quite a bit with this data. Yes?
If you search by same financial accounts, and the only data that you're going to pull out is for the specific accounts that you search for, or
all the encounters. All the encounters.
And is there a date range if you didn't specify one, or anything that's in the database ever?
It's anything that's in the database ever. We do have the capability to, if you've got it, like on my was 2014 forward, we do have the capability to cut it off and only do 2014 forward. But again, we don't always know what your research question is. So you may be interested in those that had diabetes in 2014 forward, but maybe were introduced to something earlier prior to that. So there's so many different ways you can look at this data, and we don't always know which way, so we kind of leave it up to you to use that data as you'd like. Now, oh, go ahead. I'm sorry, what?
Many of these encounters are not sepsis encounters.
No, they are sepsis. They do have sepsis in their encounter. That's part of the requirement. They do. But they may have, in this example, I'm sorry, you're correct. There are some that may not have sepsis in the encounter. That is correct. But at some point in the record, they have had sepsis. That's correct. Sometimes you get this data and you think, I don't really want to cut this down. I don't want to spend that time. We offer that for a fee. We'll clean up your data for you. If you sit down with us and tell us what your parameters are, we'll clean it up so that it's analysis ready. And that's actually Maren and Lee who will do that for you. They know this data better than I think I do now. So Does anybody have any questions about this raw data? When you are in REDCap, let me log out. There is this option to export, and this can be confusing to people sometimes. You can export, and you're like, all right, great, I want to export all the data. Well, this is actually exporting all the data that we've loaded in the REDCap. So you're exporting that last value, not all the values. If you want to look at all the values, make sure you go to the raw data. So this can be a little deceiving. This is exporting all the data in your REDCap project. So like I said, it'll export that number of occurrences for that. Let me go to an example. So if I was to export the data right now for this patient 18527, I would get that first date, that last date, and the only value I would get for the O2 is 80.8. I wouldn't get every other one. I wouldn't get the other 18 values associated with this patient. Like I said, sometimes the REDCap is enough. We've had people that are looking at risk factors. They want to see how many people have breast cancer that were smokers, or a certain demographic, or had a certain medication that they had taken in the past, or a radiation exposure. By pulling those all into your query and looking in REDCap, you could do a report to see, okay, how many of these patients were smokers? How many had radiation exposure in the past? So that kind of stuff is great, and it's so much easier to use it in REDCap. But if you're doing that detailed analysis, definitely a good raw data. Does anybody have any questions?
So opening the report, it looks like Excel, an Excel file, can't save that.
So this is it's a CSV file that's attached.
Okay.
So you can pull that, yeah. I just happened to, when I opened it, it just opened in Excel on this computer.
You said don't use the data export.
So this was in the file repository. So this was the raw data that I opened out of the repository. So if you do the export, this is the data that's loaded into REDCap. So REDCap is loaded with a lot of the data, but not all of it. Does that make sense? So when we load it into, let me go back into this one. So when we load the data into REDCap, we load the date, the first date, the last date, and we count how many times something happened. Right. But we only load that last date, that last value. And so when you export from REDCap, it's going to export that last value. Whereas the raw data is going to have a lot more information.
So then the raw data is all in the file repository.
Correct. And if it's too big to fit in there, we send it to you via secure files. Let me do an example of this export. Actually, we can view it as a report. Oh, it's going to be big, though. So this is showing you the all that patient data. That patient data would be very similar because the patient data doesn't, the demographic data doesn't change. But here you can see, this is, out of REDCap, you've got that one line per patient. And you can see for that one patient, we've got a sepsis date starting here, a last date here, the count. It's got the code associated with it. This was a certain KU ID. It's got the modifier, septic shock if it's associated, and then it's got these O2 saturation. It's got lactic acid. This is what I was going to show you. It's got that start date, that last date, and then it's got that only that one value per person. Whereas if you wanted to look with the example of the person that had 3.3 as their last, if you wanted to see that 5.1 value, you'd go to the raw data. Okay. Does anybody else have questions about that data? I wanted to go back in here and show you, let's see if I can get a patient set to open. I see you guys have been busy. That's good. I like to see lots of queries in there. Oh, good. I have a patient set here. So when we ran the query, we kicked off the timeline, and it showed you the timeline. We also have something called the demographics. If I pull a patient set, let me go back to find patients. When you run a query, all right, let me try it this way. Oh, it's not going to let me. When you run a query, you have the option to run patient set. You have option to run timeline, or you have option just to run the patient number. It's defaulted to number because it's a little bit faster. I mean, just slightly faster, but you can always click the patient set. Once you have a patient set, you can drag it up here and view results. And it will provide you with a demographic breakdown of the patient population. It's going to be very similar to what we just saw in REDCap, because this is the same search as what I just showed you in REDCap. It's going to show you how many were, how many are deceased, how many are female versus male, race, religion, all that good stuff. But this is a way, before getting a data set, that you can see what your patient population looks like. Yes?
I know we can save that data set, just like we said before. If we save it for future use and go back, do we need to rerun that query due to an update?
Yes.
Okay, so rerun it, resave it.
So yes, we keep patient sets up to 3 months.
Would it still give you the same patients that you did 3 months earlier, or will it not work?
It will if you do it within 3 months from a saved query.
Right, but if it's
right, so
new data, will it even hold the same?
So we save them for 3 months. That's not something we publicize widely. It's usually if, because sometimes, people will be doing their work and then we'll do a release on them and they're like, oh, now I got to start all over again. So we save it up to 3 months in the past. And if you pull in a previous query's patient set, as long as it's in within 3 months, you should be able to use it.
But if we can save it under our shared or personal
Folder.
save to use basically what your parameters are.
Correct.
But you could just load that patient set in, or could you?
You could. I always suggest rerunning the query. For one, you may get more patients, which might be of interest to you. And for another, unless you know for sure it's within that 3 months, you might get false recording. Like if you know it's like a week later after the release, or a month after the release, then you're fine using it.
To answer the question about patient numbers, we can go back and update patient sets at every release. But you can still use that same patient set. If you didn't care about it, you just need the same time frame, you could still rerun it down the road and not necessarily redoing that query.
Yes, and you can pull the patient sets into another query. But I usually suggest, unless you've already started analysis on a specific patient set, I always suggest rerunning it. Because like I said, you may pick up a couple extra patients that you didn't know about. Because each month we release, we get the previous month's data. So right now we are on HERON Quakerville, and we've got data through the end of October 2016. You can always tell which release we're on up at the top and how fresh the data is. Next time we have a release, it'll be up through, we actually are, we didn't do a November release this year. We're going to do an, I'm sorry, we didn't do a December release this year. So I will do one in January that'll be through the end of December. And here's that demographic tool, so you can see an overview of your population. Because if you're submitting for a grant proposal and you found the number of patients that meet your criteria, this is some great information to put in that proposal as well. You'll know how many of them are female versus male. And you can do individual queries in here and say, okay, this is my patient set. Pull in female, run it. Pull in male, run it. This is a quick breakdown for you. Shows you the number as well. Right. Does anybody have any questions about that? We're going to break for lunch. We'll be back here at 1, and it's going to be time for you guys to do searching, and we'll have members from our team walking around answering any questions. Like I said, best way to learn Heron is to get in there and search. And once you're trying to find the right data concepts, it can be a little confusing or frustrating, and we're definitely here to answer any questions. So